The biggest thing, I mean, you can see we're going to lecture and we're going to do those different PowerPoints. On the 10th, we're going to do sites for injection. So I may have some dummies in here. Wear something comfortable because we're going to be feeling all over each other. Okay? We're going to be going. I don't know if that's going to sound right, did it? Okay, we are going to be exploring's not any better, but just we're going to want to make sure that we get to feel the different sites on different people, because that's the best way that you can figure out where, because everybody's different. Okay, everybody. I mean, hopefully we think that the greater trochanter is in the same place of everybody, but you know, it may be more difficult to feel on people. I have the best trochanter. When I pull my little knee out, it just pops right out, so you can feel it real good. So I still have a little fat on there. Just don't mind the fat. Just feel the bones. But I want you to be able to wear something comfortable so we can get to the areas and we can practice on each other too. Okay? The 17th. We're going to start the dreaded medication calculations. Okay? It is awful when you start, but we will get it. I have been trying for 2 weeks to download this big booklet that I put together with oodles of medication calculation practice questions. I have been trying to scan it. I have went down to the IT people. I'm tired of doing that. So what I'm going to do is I'm going to make a copy for everybody. Yes. Okay?
Thank you.
I might get fired. But if I get fired, y'all can stand up and say, she did it for us. Okay? So will y'all defend me to the end? So I'm just going to go and I'm going to make, so on this class right here, you probably won't need to bring anything, these two, you probably won't need to bring anything except I'll have that pamphlet for you, or that booklet. I mean, it's probably about 40 pages, but it has oodles of practice questions on it, and we're going to go through each, we're going to go through them and we're going to have it down pat. On the 22nd, you haven't done the Group A, Group B thing yet, have you? Okay. So have you been given a list of who's in Group A and who's in Group B? All right. Group A only is going to come on the 22nd. Group B is going to be home that day working on all those assignments that I gave you, like the methods of calculations or all that kind of
All
stuff.
that testing stuff on the CD.
Right, all the stuff on the CD. That is going to be your assignment while you don't come on this day. Okay, we're going to be here from 8 to 11 and then 12 to 2. Now, I have Bring Lab Kit with equipment. You haven't received that yet. I have thought about that on the way to work, and I'm not going to give it to you till this day, because what will happen is I'll give it to you today, and then on this day you won't bring it back, and then you won't have any supplies, and then I'm going to have to take time to go get you some supplies, so I'm just not going to do that. Okay? I'm just going to give it to you this day. All right? Now, the next day, Group A don't come to class. Just Group B comes. Group A will then be at home working on their assignments just like Group B did the day before. Okay? Does that make sense? Where is the Group A, Group B? Under lab. Under lab. Alright, now you can see that on the 22nd and 23rd we're going to be practicing injections and practicing all that good stuff. But we're also going to have an opportunity for you to ask questions, hopefully towards this 12 to 2 time, about calculations and making sure that you got those down pat. Okay? But we're going to actually do a lot of hands-on that day. Now, the 24th is the dreaded day. Okay? That is the day that you're going to get your medication calculation test. You have to make 100%. Did you hear me? 100%. Now, since I'm the nice person that I am, I decided to do this a few years ago, which worked very, very well. You will also have to check off on these 2 days, and we'll have a sign-up sheet for check-offs. Okay? On these 2 days from that time, I am going to let you do that medication administration test, and when you make 100 on it, that is what you're going to use to check off. Okay? Now, in the past, we have had you do the medication administration or the calculation test, make 100 on it. Then when you got ready to do check-offs, you had to come back in and do another set of calculations and then go carry it out and check off. I'm not going to do that. I'm going to let you use your test that you did your medication administration on and made 100. That's what you're going to use to actually administer medication to your patient. Okay? So you're not having to test twice on the calculations. So it cuts a little time down, plus it cuts your anxiety down. Because making 100 on a test is very difficult. But do you understand why we make you make 100 on this? It's important.
Oh, yeah.
Because I don't want you to give me any medicine that you only got 80% right. Because that means that you're going to be giving me stuff that is the wrong dosage. And I would prefer not to get the wrong dosage. Okay, I want the 100%. A lot of people don't understand that, but I can tell you, you have got to have this right all the time. Period. End of discussion. Okay? The bad thing is you can't use a calculator. That's the bad thing. Now, in the hospital setting, by golly, bring your calculator. You will see me using a calculator because I can work it out on my own hand, but I always go back and check it with a calculator because I trust that calculator a whole lot more than I trust it sometimes with my math. Okay? So that's how this unit's going to run. Any questions about how we're doing stuff? What's going on? I know I didn't explain it that well.
So on the 25th, we're going to have open lab. On the 28th, if we've made 100, then we take that test, and we're going to check off and give our patient medication.
Right. You're going to anything that's open lab here, we will have somebody there for you. Okay? One of the instructors will be in there, or several of us will be in there for you to practice. Now, that lab is your lab. If there are any times that you say one day after class, you just want to go in there and practice a little bit, all you got to do is come to one of us. We will open the lab, get in there, and practice all you want. You may not necessarily have an instructor in there with you, but you know we're generally here so you can come and ask us questions during while you're doing it. But anytime you want to use that lab, please just come get one of us and get in there and play in there. Play on those dummies or whatever they're called, models or whatever they're called, just so you can, welcome. I'm being nice today.
I was here.
Well, you weren't here at 8:30, so.
I was here at 8:30.
But you ain't sitting outside at 8:30.
Oh, my bag is.
Being nice today. Anytime y'all want to use that, please go in there and use it because it's there. But the open labs are there. So you're going to take your test here. Okay? If you do not make 100, it's only going to take you probably about an hour to do that test, if that. So those of you that make 100 will go home. Or you can go to the lab and go ahead and practice. Now, mind you, I will be taking the test up. So you can't take the test with you. Okay? It'll be with me. But this is the time we're going to use for remediation to help you figure out where you went wrong with your medication calculations. And then you will have the opportunity to retake the test, and it'll have to be on the 28th. So if you weren't successful the first time, you're going to have, even if you're not scheduled to check off, you're going to have to come retake this test again before you can check off, because you have to have 100% before you start. You get 3 chances. Okay? The first time you do it, you don't make 100, we remediate you. The second time you do it, you don't make 100, we remediate you again. The third time, if you do not pass the medication administration exam at 100%, you will be out of the program. Okay? You have to pass this at 100%, and you get 3 choices, three chances. Okay? Sorry, busted your bubble right then, didn't I? Sorry. Just want to be honest with you. Tell you up front what's going on. Okay? So that is, so it's vital to see that we've got to get this down pat at 100%. This is how serious this is. Okay? Then after we check off those 2 days, then the 30th we will have our unit test. Okay? And I think this might be a day that she changed it to 8:30. But I'll tell you, I think she changed it to 8:30.
Now, if we come in, we make a $100 test, we come in on the 28th, we check off, do we have to be here on the 29th?
Says only if everybody checks off on the 28th.
We won't tell anyone
Come in, check off.
That's the CD stuff. It says do we give you the workbook, or do we just do all the things on the CD?
No, that's, she made a mistake on that and she reposted it. You do everything on the CD and email it to me. You do not turn in your workbook on that.
So all of these that are listed, we do that, do a unit on the CD and email it, right?
Yes, all the ones that are listed under the lab, the calculating drug dosages, you are to do all those on the CD. Okay, on the CD. And then the other, the HESI stuff, you do it on HESI, and email it to me. I don't even think you have to email it there. I think it just sends it straight to me.
Do we have any other reading that we need to do for this unit, or?
Well, I think I posted the pages, didn't I?
I didn't.
No, I didn't. Oh, Lord have mercy, Miss Wild Girl. Yeah, that's changed to 8:30 that test. Miss Walker didn't do the test? I mean, the readings? Lord have mercy.
We thought we got lucky.
I can post those for you. I'm sorry, I apologize. I did not, I can tell you which unit it is. It is chapter 35. Chapter 35 from 8:41 to 9:14. I think that's the whole chapter.
That's cool.
I think it's all in one chapter. I'll check again though and make sure, but it's chapter 35. Okay, so we're going to be using lots of class notes and PowerPoints. Okay, you may not think that's a lot of reading, but that's a lot of information. You're going to have to learn all the sites. You're going to have to learn the syringes, what syringe needle I need to use, the length I need to use to make the decision on what I'm going to give my patient. So it's a lot of information. It may not be just one chapter, but it'll be a lot. The other thing that I did is there is a lot of reading, or there was a lot of reading with the classifications, but I want you to use just my PowerPoint for the classifications. That pharmacology book is very difficult to read. It is very difficult to understand, so I want you, for as far as classification, medication classification, PowerPoint, that's what I want you to do. Okay, I want you to focus on that. Because that is, you know, I always tell you that you don't memorize stuff in nursing. This is when you're going to have to start memorizing stuff. We're going to learn antihypertensive medications. Okay, when you learn antihypertensive medications, you're going to learn a lot of different things that go. So anytime you see a patient that has an antihypertensive medication ordered, you can immediately know that is to treat high blood pressure. And you know one of your nursing interventions is going to be check their blood pressure. Okay, so I've got it pretty well the way I want it on here to get you to start learning medication classifications. Okay, that is going to be a number one. We got to learn it. Okay. Now, I did. So you actually have two PowerPoints: one medication PowerPoint and one medication calculation PowerPoint. You also have all of the lab assignments on the CD. Okay. You also have a class assignment, which is the medication classification assignment. And I'm going to pull this up for you and show you how. It's called At the Med Cart. And it is a fill-in-the-blank assignment. But I have given you the words at the bottom. And you're like, oh my God, this is very elementary. It's not. It's not that elementary. But when you are going to be worried about the types of things I'm going to ask you when we get into the clinical setting about medications, these are the kinds of things I'm going to ask you. Okay? So it's going to be more of a, let me get this organized when it comes to ACE inhibitors. And this is the kind of stuff Ms. Walker's going to ask me when I get ready to administer an ACE inhibitor. Okay? And it goes through several different classifications. Now, as far as, it goes through ACE inhibitors, anticoagulants, antibiotics, lots of stuff on antibiotics, nitroglycerin, digoxin, and it goes on and on and on, right? And your beta blockers. Okay, so that's one of the assignments that you need to do. And I actually put it there is due October the 7th before midnight. You can type the answers on a Word document and email it to me. I'll put the answers up for this assignment because I want you to keep this because you're going to use this as you go to clinical. I'll put the answers up so you can actually download your assignment and keep it with you. So you'll have the right answers, okay? There is a little note that says this information will also be included on your unit test, okay? So this assignment is going to be, you're going to see the information over again, okay? So make sure that you got that down pat. All right, any questions about what's I've got up here? The other thing I've got, well, let me just put here. These little funny medications, I'm a very visual person, so I'm hoping that these little funny things will help you when you're looking at different medications. So if you didn't print those off, you need to print those off and those will help you. All right, any questions about what all I've got up here?
I was working on memorizing some on the funny meds things.
Mm-hmm.
Is it better to know the one in the parentheses or the one above it? Because I was memorizing this term here. Do we need to know these as well?
Okay, I'll get to that in just a little bit because yes, you are going to have to know both trade names and generic names.
The information for our assignment that's due on Monday, is it all in our PowerPoints or like where where do we go to?
The majority of it will be on your PowerPoint. I don't think, and you may have to go look at your drug book, but it's a pretty straightforward assignment. Especially since you got the words right there. All right, any other questions about? No? Y'all understand, Lee? All right. All right, medications. Here we go. I know everybody's nervous about this because it's such a vital part of nursing. So I'm hoping that I'll make it interesting enough so you can understand it. Administration of medication. What is a medication, first of all? It's something that we're going to give someone to assist in the treatment, and it's not always to cure them. It may just be a treatment for them. I'm going to give them a medication. Hopefully it's going to help them. I think I'll look at it that way rather than it's not always going to cure them. Now, I know what, no, I don't want to go there. Okay, so we may want to relieve a symptom. Give me an example of something that you take medication to help relieve a symptom. Ibuprofen. You have pain. You take ibuprofen, the pain goes away. Okay? So that is the reason why we give a lot of medication. I use the term drug and medication a lot as the same thing. But sometimes when you think about drugs, you think about them being illegal type of drug. And when you're communicating with your patient, that is probably what they're going to associate if you use the word drug. So it's better to use medication with them because especially our older people, they will be offended when you say, what kind of drugs are you on? They're going to immediately think that I think they're doing marijuana and cocaine. Okay? So use the term medication with them is a little bit better. The other thing that you're going to see is when we ask these patients the history, I also need to include, are you on any type of illegal drugs? And at that point, that's when you use the term drugs. Okay? Because it may not be the correct terminology, but that is going to be what the patient understands. Okay? When I say, are you taking any drugs, I mean, do you smoke marijuana? Do you use cocaine? Do you use Roxy?
Do people tell you the truth about that?
No.
Okay. I was just wondering, because I would think that they would.
No. It's the same thing with alcohol. You know, you got a patient coming in, they reek of alcohol, and you say to them, do you drink? No. Yeah, they're not going to be, and the way I handle this, when someone says to me, when I say, do you do any illegal drugs like cocaine, marijuana, anything like that, and they say to me, no. And I'll say, well, you know, I really need you to be honest with me because the way I'm going to treat you and some of the medication that I may be that the physician may be ordering for you may react to if you have any other drugs in your body. So I want to make sure that the medication that the physician's going to prescribe to help your signs and symptoms is not going to interact with an illegal drug. Okay, so if you do it that way and you try to explain to them, I'm wanting to help you. I'm not here to judge you. Okay? And let them know, be honest with me. And that's when you develop that relationship and rapport with them so they can feel trusting in you and that you're going to make, and it's all, if you turn it around to be all about them and making sure that their care is going to be appropriate, and I don't want any other drugs messing with what we're going to do. Because we can have more problems if I give you this and it interacts when you're doing cocaine. Okay?
Won't they be fearful of getting arrested? You know, if they admit,
But HIPAA,
can you say that?
it's HIPAA. I can't go out and tell a police officer that my patient in here is doing cocaine.
But if there's an abuse of a child or something,
Oh,
that's
yeah.
when it's reported.
Yeah, yeah. But as far as I'm not there to, I can't go out and tell anybody that Robin is in here doing cocaine. All right, so I can't. Shh, don't tell nobody. That's I can't do that. HIPAA refuses. I cannot do that.
And we can
It's
say
a
that to
violation.
them.
Yes, rest assured that what the information that you're giving me is kept confidential. Okay, but you've got to make them understand that, or help them understand that whatever illegal drugs they're doing is going to have the effects of the medication that we give them may not have the correct response to it if they have illegal drugs in their system. Okay, alcohol in their system. Okay, so it's very important. And yes, you're right, they're not going to be honest with me. But all I can do is try. All right, prescription. Everybody knows a prescription. You know what a prescription is. You go and you get medication from a physician. It is the written responsibility. The physician's is his responsibility to write a prescription. When you're in the hospital, when he writes an order, that is considered a prescription. That is an order that is prescribed for that patient. Okay? You're going to have to learn, or you're going to see a lot of prescriptions when the patient is discharged. The physician will write an actual prescription for the patient's meds that he's going to go home on. So you're going to actually see prescriptions of that you're going to give your patients as they're discharged. On a prescription pad, it has to have the physician's name. It has lots of information on there. I know y'all have all heard how nurses go and steal physicians' prescription pads. Y'all heard that? Nurses do that. We do that. I mean, not we, but, it's seen that they do that. Do not get yourself in that situation. That is a legal issue, and you will lose your license just like that. Okay, you cannot take a physician's prescription pad and go write drugs for your whole family. Okay, not going to work. Does anybody know what pharmacology is? Maybe sort of. It's the study of drugs. It's really the study to see what happens when we give a drug to someone and they ingest it, and I want to see what's happening in their body. So it's very important when we start giving medications to someone that we understand what type of effect that medication is going to have when I give it to that patient. Okay, so we've got to understand the pharmacology with it. Are they being as loud as we are? I can be louder than them. All right, pharmacy prepares and dispenses drugs as ordered. I'm not going to spend a lot of time. I think that's pretty self-explanatory. Let's get to the nursing stuff. All right, things that you need to know. Well, that first section was just some definitions to go over. So let's get to what we need to know when it comes to getting ready to administer medication. I know everybody fussed and says, oh my gosh, I really don't want to take all these extra courses. I just want to get into the nursing course. Well, there's a reason why we have you to take anatomy and physiology. Okay, there's a reason. There's a reason why we had you be qualified in chemistry. There's a reason why we had microbiology. Because you're going to use all that information that you learn through those courses to help you apply administration of medications. Okay, so yeah, there is a reason why we, obviously A&P. We got to know what happens when in the pancreas before we start normally, before I start giving somebody some insulin, right? Because I don't know what normally happens. Then I know I got to look up the pathophysiology to see what happens when the patient's a diabetic. So I got to see what this medication, what do we want it to do? So there's a reason why I need you to understand anatomy and physiology. Anybody taking A&P now? Everybody got it under the belt? Woohoo! Wonderful. All right. This is one of the hardest things that you will ever do in nursing. You will never, ever, 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 ever have no up one side and down the other every medication that's out there. You're not going to do it. I can't do it. That is why we carry drug books. That is why we have resources out there. Please don't get discouraged because you can't get everything with all these meds. It will come. It is a gradual process. The more you administer Lasix to that patient, the more familiar you're going to be with it. The more you administer digoxin, the more you're going to be familiar with it. And there's going to be some drugs that you know up one side and down the other that you don't have to look up when you go by and see, oh my gosh, my patient's getting this. I remember this. I really need to watch for this. But when you get to the point where you, and I'm talking as a nurse, that you see a medication that you're not familiar with and you go ahead and administer it, you are not providing safe care. You have got to use your drug resources. Example, if we're in clinic and you have looked up, oh, I can tell you, Alicia, y'all thought I was picking about medications and the amount of medications that are given on IP. How many medications did your patient have to be given at 9 o'clock? 25. 25 medicines that we were going to give this patient. Whew. They thought I was picking, but that's what it was. When you get in that situation as a nurse, and even as a student, you're going to see medications that you're not familiar with. That is why you have a drug book. And I can tell you at Northeast, what is really, really wonderful, and I don't remember who we did it. I showed somebody. If you have a medication listed there and you don't know what it is, all you have to do is right click and it will pull up that reference manual for you. So there is no excuse for you not reviewing a medication before you give it to somebody that you don't know. Okay? You have got to you've got to use your resource. Okay? Now, I think one of the biggest things that I get excited about is when I when I can finally figure out what this medicine's going to do for the patient. Like I understand the pathophysiology of the disease process. Then I look at this medication. I'm thinking, what is it going to do to the body to make my patient better? So if you look at it in that way, so you're not just giving them meds for no reason. You got to understand the reason why you're giving it to them. And when you want to see, one of the biggest things that is wonderful for students to see with a medication is Lasix. Does anybody know what Lasix is? It's a diuretic. Okay, what what does a diuretic do? It makes you pee, doesn't it? Literally, in a lay person's say, it makes you pee. So when you give that patient Lasix and they go pee 800, isn't that wonderful? Because you're actually seeing a result of what that medication does. And then you're understanding, hey, my patient has a lot of edema. in their lower extremities. I got to get rid of that edema by giving them Lasix, and then I see them pee. And then I see the edema in their legs go down. That is the way you need to look at medication administration. What am I doing for my patient? And yes, it is a challenge. All right, drug. We just talked about that. Most medications there are several reasons why we give medication. To prevent things from happening. Give me an example of something that you would take to prevent something from happening.
Blood pressure medicine and prevention or cholesterol, so prevention for heart attack.
Immunization.
Okay, so let's back up here. High blood pressure medicine. Why are we giving it? Maintain the blood pressure, right? Is that a prevention?
No, that's a maintenance.
That's a
Reduction.
reduce. I want to reduce the chances of them having high blood pressure. Now, high blood pressure puts patients at risk for heart attacks. So, yeah, it's going to reduce their fact of having heart attacks. But when I look at my antihypertensive medication, I've got to look. I am reducing my patient's chance of having symptoms of high blood pressure. Does that make sense? So, antihypertensive.
I was just gonna say the flu vaccine.
Flu vaccines. What is that? What type is that? It is a prevention. So I'm going to give somebody, which sometimes doesn't always work, because every time I get a flu shot, guess what I get? Right. So heparin is anticoagulant medication. So that's actually preventing someone from getting a blood clot. What about reduction? Yeah. Different medication, yeah. And you got to really look at it to see, what am I giving a sample? Exactly. Like a patient has high cholesterol, and cholesterol does what to your body? What do you do in your vessels when you got elevated cholesterol?
Plaque buildup.
Some plaque there. So it's already there. So I want to reduce it and get rid of it so I don't have to take cholesterol.
Would immunization be prevented?
Prevented, yes. Immunization. What about antibiotics are going to be to cure because we've got a infection and we've got to give something to treat that infection so it's going to cure it. So that's going to be something because infection can be cured, right? Mm-hmm. Can high blood pressure be cured?
No.
It can be
Managed.
treated and reduce their chances. Nitro is going to be what? What is nitro?
Reduce.
What happens with nitroglycerin? What happens with, why would you give somebody nitroglycerin?
Having a heart attack.
Chest pain, exactly. Don't go in there and medically diagnose, because y'all all said heart attack. Symptoms, what are they having? Chest pain. That's what.
You're trying to prevent a heart attack.
Trying to prevent a heart attack. Is it going to cure? It's going to help prevent it from happening. See? Yeah, and you can give them something. So it actually could be prevent and reduce. Okay, so you can have several things that work the same, but always think, if I'm going to give this medication, what is it going to do? Okay, is it going to help prevent something? I always have to understand why I'm giving this med. And I will tell you, when you're in the clinical setting and you're verbalizing your medications to your instructor, they are going to ask you, why are you giving this medication to this patient? I'm going to ask you that right up front. Why are they getting this? And you need to be able to tell me. this, I mean, I don't want you to say, well, it's going to prevent this or it's going to cure this. And I want you to tell me why I'm going to, I mean, you don't have to use these terms, in other words, what I'm saying. I want you to say to me, or I'm saying, why is your patient getting antihypertensive medication? Because my patient has high blood pressure. How do you know that? He's got a history of it. So he's on this medication prior to. So what do you want this to do? I want to lower the blood pressure. So you have to know why you're giving that medication to that patient. Okay? Because we do individual care for our patients. Okay? Why are they getting it? There are going to be times that you have a patient who has a medication and you say, I don't know why. I have looked this medication up. I cannot see anywhere where we have, my patient should be getting this medicine. I don't see any disease process that this medication should be treating on him or her. There are going to be many times that patients come in and we don't know why they're getting something. What would you do as a student when you have a medication that you cannot figure out why this patient's getting it? Ask who?
The patient.
The patient. You know, I see that you're on whatever. Can you tell me why you're taking that?
I had a patient on Coumadin, and I had to figure out why he was on Coumadin.
Right. Yeah, and you know what? You probably go in there and say, you know what? I have atrial fib.
He said, well, I had a blood clot.
Right. So a lot of times a patient, and they may go in there and say, I have no idea why I'm taking that. My wife told me to take it, and she puts it in my pills, and I take it every day. Okay? But at least we've got to figure out why we're taking that. I mean, what do you take? And a lot of people, remember, I think I told y'all this earlier, a lot of people don't consider vitamins or fish oil or cinnamon or whatever they're taking. They need to be telling us this stuff. For instance, fish oil. I need to know if that patient's on fish oil. Because what if something happened that they had to go to surgery? What does fish oil do? I know.
Does it thin the blood?
It thins the blood. So it puts the patient increased risk of bleeding. And if they go to surgery, I need to know that. If it's emergency surgery, then there's nothing I can do. I can't tell them to stay off of it a couple of days. Excuse me, you're having emergency surgery. I can't operate on her because she's taking fish oil. That's not going to happen. But what's going to happen is, if it's an emergency surgery, I know that the patient's been on fish oil, so I know that they're at increased risk for bleeding. So what do you know that I'm going to have right there readily available? I'm going to have some blood on it. Is that going to help me in my treatment of my patient?
Yes.
All right. That was a good little discussion. I like things like that. I like that. All right. We have a classification. That is something that we are going to ask you too. What is the classification of that medication? Please, when you are learning medications, it is easier to learn medications if you learn them under the classifications. Okay? Do you know what I mean by that? In other words, if you learn antihypertensive as a classification, there are going to be certain things that you do with every antihypertensive medication. So when you first look up a medication, you think, oh my goodness, that's an antihypertensive. Oh, I remember I gave another antihypertensive to my last patient, and I remember I had to check his blood pressure while I was lying, standing, and sitting. I had to monitor his potassium level. I had to do this. I had to do that. So when you see that term antihypertensive, some of the information is going to start coming back to you that you know I need to do. Then you can actually look up the drug and see what is different about that one, because they give antihypertensive for different reasons. Yeah, to lower the blood pressure, but it also depends on where is the increased blood pressure problem. Is it in the aorta? I mean, in the what's the first atrium? Is it a ventricular problem? So they're going to give them antihypertensive for different reasons. But when you hear antihypertensive, you're going to immediately know, I got to worry about blood pressure. Anticoagulants. What do you think of when you hear anticoagulants? Blood thinners. So what do you think of when you hear anticoagulants? What do you think the patient could be at risk for? Bleeding. Could be at risk for bleeding. So your nursing intervention starts already thinking, doesn't it? Oh God, they're on anticoagulants. That means they could bleed out. I better really be watching this. Okay? Give me another example. I don't know any classifications this Walker. What are you talking about?
Beta blockers.
Beta blockers, that's also antihypertensive, and they're divided. I don't expect y'all to know this. I'm just throwing some stuff out at you. See how smart y'all are. That's what I want to hear. I want to hear some insulin. I'm going to tell you right up front, and I want everybody to listen to what I'm saying. You better know your insulins. When you administer insulin to any patient, you better know the peak of that medication, of the insulin. You better know the onset, and you better know the duration. Do you know what I mean when I'm saying those terms? All right. Insulin is a medication that works different at different times. The onset of it means when you administer that insulin to that patient, the onset means when is it going to start working? Okay? The onset means when I administer that medication in that patient's abdominal area or wherever I'm giving it, subQ-wise, when do I need to see that this medicine is going to start working? Because it's given to decrease blood sugar, right? Mm-hmm. So if I've got a patient who has a high blood sugar, it is going to take me 30 minutes, or this medicine 30 minutes, to get into my patient's system. So I know at least 30 minutes, that's when it's going to start working. So I need to be looking at my patient to see if there's any signs and symptoms that they may be experiencing, because it may go boom. You know, obviously I want it to gradually bring it down, but insulin, because everybody acts different, you can give it to someone and within 15 to 30 minutes they have bottomed down to the glucose. What's the normal range of glucose? 60 to 110 or 70 to 120. What ranges do you use?
I mean, for me, it's completely different. Being type 1, I've got a different kind of goal. I mean, below 200 is good for me.
Okay, you got it. Ashley, what about you? What's your
About 70 to 120.
70 to 120? So that's the range that most.
There's different part of it, like it needs to be like in the upper like hundreds, like below 200.
So you're both, since you're diabetic, you definitely have different goals. But and anybody that we give insulin, obviously, is going to be some type of diabetic. We don't just give insulin to people because we want to. It's not one of those drugs that we want to give everybody. So I want to make sure that range. So if I've got somebody who's 300, their blood sugar is 300, then I give them insulin. So I know that the action of insulin is to bring the blood sugar down. But what if I gave them too much? Then they can go down to 30 really quickly. So I need to know if I'm going to administer that medication and it's going to start acting in 15 to 30 minutes, I better be in there assessing my patient after that at that time. So that's the onset of it. Peak means when is this medication going to be at the highest level it's going to work. So if I give my patient some medication at 8 o'clock, some insulin at 8 o'clock, it's regular insulin. I know that it's going to start working in 15 to 30 minutes. But the peak of it, when it's the best it's going to be, is 2 to 4 hours. So I have to watch my patient between that 2 to 4 hours because I know as a result of what I gave them, that medication is really going to start working and they may bottom out again. The duration means how long does that medicine last? 6 to 8 hours. So when you get, and the reason why I'm telling you this is when you administer some medications, you can't stop assessing your patient just because you gave it to them and then we're not going to worry about it anymore. With insulin, you can't because the insulin has so many different time frames that it could be doing something to the patient and I need to be aware of it. Okay? So anytime you administer any insulin, you know that you're going to do the peak, the onset, and the duration, correct? Do you know that your instructor is going to ask you that? So every insulin you look up, you need to have that information. Not just to please Ms. Walker, is that you know that if you administer that insulin, there are certain time frames that you have got to go back in to that patient's room and reassess them to see if they're having any signs and symptoms of the medication not working correctly. Okay, it's not about just telling Ms. Walker, although that does help. It's about you knowing what you need to watch with that patient. Okay? All right, so therapeutic. I want to see a therapeutic range happen with my patient. What does therapeutic mean? Not communication. Therapeutic. Good. Good. That's what we want to see happen. Okay? This is what I need to see happening with my patient. And I gave you a couple little examples: anticoagulant, antihypertensive, antihyperlipidemics. You know what that is? Cholesterol. See how you're starting to click? And these are classifications. So that's why I need you to start learning. When you think antihypertensive, blood pressure problems. Anticoagulation, blood thinning. All right, and then the pharmacological thing. How does the medication act in the body? When you're looking up your medications, you're going to see in your drug book an action of the drug. Action. That is what you need to understand. How, and the action means, how does this work in the body? What happens in the body to make this patient lower his blood pressure? For example, patient's got high blood pressure. We're going to give him a diuretic. A diuretic works by what? Getting rid of fluid, but really, in your book's going to say it's lowering the plasma volume. So what does that mean? Getting rid of fluid in it. Basically, getting rid of fluid. Okay? There's an increased volume. We need to get rid of it. All right? So when you look up drugs, the action is going to be something that you need to understand of what's happening in the body, because we're going to ask you that. Tell me why your patient's getting this medication. They have high blood pressure. Okay, what is Lasix going to do in the body? And that's going to be the action. And you're going to tell me, well, it decreases or it lowers the plasma volume. Okay, what does that mean? See, there's going to be lots of terms in there that it's going to sound good if you memorize it and say, yeah, Miss Walker, this Lasix, it decreases the plasma volume. And then I'm going to say, so what does that truly mean it's happening? There's a difference between memorizing and vomiting it back up to me than truly understanding what is happening in the body to make that patient lower the blood pressure. So yeah, if you come in and you're vomiting all this stuff back up to me, I'm going to continue to ask you questions so you understand really what is happening. Okay? So it's an action. I want to know why this is happening in the body. And I gave you another example of calcium channel blockers. All right, y'all ready to take a break? All right, as far as what we need to do, and I think I pretty much went through a lot of this stuff about how the patient or how the medication actually works. That is your responsibility. That is the action of the drug, and you need to know how it works in your body. When we did the nursing process, we actually had an area in our intervention that said administer. So if you have a nursing diagnosis that is going to represent a problem with your patient, obviously, and you administered a medication for that problem, you can actually write administered the medication on there, and I think we talked about that, because it is an intervention and it is part of the nursing process. So don't look at medication administration as a separate entity. It is all a part of the nursing process. Everything we do revolves around the nursing process. Okay? So medication administration is part of that. So that is something you are doing to help your patient get better. Okay, so always include your medication, but you have to realize, for instance, if you had a patient who had fluid volume deficit, okay, and you administered some IV fluids, but you also gave your patient an antihypertensive medication. In your nursing process, are you going to put that antihypertensive medication under the fluid volume deficit? Because that blood pressure medicine had nothing to do with the fluid, unless it was a Lasix. But you see what I'm saying? You want to get your nursing diagnosis, the medications that you administered for that problem. Don't list every medication that you gave your patient if it had nothing to do with the problem of that nursing diagnosis. I'm still getting some blank looks. Not getting what I'm saying? Talk to me.
Where do we put the drugs then that we are giving for other things? We're not putting it there, but are we just?
Right.
I'm trying to follow
You may
along.
not have to put it on your concept map if you did not administer that medication for that problem.
Okay.
It's not the fact
Just
that
the
you
concept
didn't
map.
do it. Yes. It's not the fact that you didn't do it. Yeah, you did it.
Right.
But in order for you to meet your goal with that nursing diagnosis, don't put a bunch of meds in there that's not going to help you meet that goal.
Okay.
Does that make better sense? Of it? Because you're going to give lots and lots and lots of medications, but it may not be one that, see, that's going to help you understand why you administer that particular medicine is going to help this particular problem. Okay? So, you may, and that's a little hard to do because you immediately think, I got to list every medication that I'm giving my patient on my concept map or on my plan of care, but it may not be helping that problem. It's not going to, and you can put it over to the side if you want to. These are all the meds I gave. me and Alicia were going to be 25 the other day. Every one of the patient's medications that she gave didn't help her ineffective airway clearance. Only the, her breathing treatments and her Solumedrol. So that was the only two things that helped that have given her to help her ineffective airway clearance. Does that make a little bit more sense? Because remember, we're individualizing the plan of care for this patient to help meet the goals of our patient. Now that we're talking about meeting goals and this has nothing to do with medication administration, but Alicia's patient, you want to tell everybody what? Yeah. All right, her patient had pneumonia, had COPD, not pneumonia, excuse me. Had COPD. And one of the interventions that we had talked about doing was an incentive spirometer. And we had actually talked about it in pre-conference. And I showed everybody how to teach somebody incentive spirometer. We go into the patient's room, she doesn't have one. So what do? We go get one. And what do? Went in there and taught her how to use the incentive spirometer. You know what an incentive spirometer is? You know, with the thing where you breathe in it and it makes it go up. And it's supposed to help loosen up a lot of secretions and a lot of mucus. And guess what happened? When we did it, she did it 3 times. And guess what happened? She pulled up all this green junk. We actually did an intervention and it worked. Can you believe that? We were like so excited. I mean, we were in the room going, whoa! You know, she's bringing up the snot, because I don't like snot. And she just bringing it all up. She's coughing. And me and Alicia was going, whoa! We actually did an intervention. And that's what nursing is about. When you actually see it in front of your face and you're like, oh, yeah, there's a reason why I'm doing this because it's going to help her. And what was her comment?
I should have had that a long time ago.
Should have had that a long time ago. But Miss Walker gets in there, we're going to do it. We're going to get all these interventions. We're going to get that patient better. But anyway, okay. All right, nurses need to understand how. This is another issue that's really bothersome sometimes when you administer medication. Is once you start, especially when you have somebody who has 25 meds, you're going to start seeing this medication saying, don't give with this medication. And then you're going to see another one that says, this shouldn't be given together. When a patient's on 25 medications, you're going to see some interactions between some of the drugs. And you're going to realize, once you look at each one of those drugs, that, oh God, maybe that shouldn't be given with this. Sometimes there's not a thing that we can do about those types of things, except talk to the physician and say, look, I saw, and this is what I do, or I'll call the pharmacy. I see that this drug and this drug, if they're given at the same time, they don't work as good. Is there any way we could change the times and maybe give this one in the morning and this one at night? So you're going to see that a lot of times. It's easier for a patient to say, especially if they have 25 meds, and it's easier for them to take them all at one time. So they won't forget during the day. But you got to look to see how are they interacting with each other, and are they getting the best effect of what it's supposed to be doing. And I think that's one thing that's so frustrating as a nurse, is I think that we just tell patients to take these meds and they take them and it may not be doing what we need it to do when we need to do it. I'll give you another example.
Yeah, I have a question. Whenever you have a patient that is taking that many medications and they have a reaction, because I'm sure some of the medications have the same potential reactions. So how do you discount, oh, this medication is actually causing the reaction and that was not? At that point, how do you do that?
It's very difficult. It is very difficult at that point because I can't diagnose. What I can do is I can look at the physician or look at the patient and say, these types of symptoms are happening. This is what has happened with all the medications I've given. Then I would make a list of all the medications that could have caused the problems. And then I go to the physician and I say, look, this patient's on these medications. This is what's happening. We got to figure out which one could be causing these problems. I put it to his, because I can't diagnose, I can't change my patient's medications. I have to communicate with the physician and say, okay, and the pharmacy. So it may not be a quick fix.
Might be trial and error.
It may be a trial and error. Let's pull her off of this one and see how it does, and see if the symptoms get better. You see what I'm saying? So I wish I could say to you, this is what you need to do when you have that situation. It's not that easy. And that's what happens a lot of times with our older patients. When they go to the physician, they end up, they keep them on all their home meds that they've been taking, and then they go and they say, well, let's add this, and let's add this, and let's add this. And they don't sometimes look at everything else that the patient was on. For instance, my dad was on, the medication just flew out my brain. He was on some medication, and when he went into the hospital, they prescribed him something else. And so I had a list of everything he was on, and when we went to the pharmacy, I said, I need to make sure that this medication can be given with everything else he's been on. And come to find out, he could not take an ACE inhibitor with another medication for his breathing. And the physician wrote that order for him. If I wasn't involved in his care, he would have taken that medication and interacted. It would not have benefited him at all. But everybody doesn't have that luxury of having someone to say this medication. I didn't know all the details, but there was something in my gut telling me that I don't think he needs to be taking this medicine, this medicine. So pharmacy is who you need to depend on. Okay.
One of the doctors had told me about my grandfather, that's why you want to find one place, one pharmacy. Even if you have to pay more for certain drugs, because their computer's set up to flag stuff.
Exactly.
But if you take things everywhere to try to find the cheapest price, nobody's going to know what you're taking.
Nobody's going to know what you're taking, exactly. And I always encourage every patient I've ever taken care of, always keep a list of every one of your medicines on you. In your wallet, in your pocketbook, somewhere. To whereas if you've gone to a facility, if you're in an accident, or if something goes on, you have a reaction to something, when you go in, they can see everything that you're on, and they can evaluate to see if any of those medications or problems was causing the issue that you just had. So I always tell people, make sure you get. It drives me crazy when I go into a patient's room and they'll say, I don't know what I'm on and I don't know what it's for. Well, we're going to change that right now. We're going to sit down and we're going to talk about every one of these medications, and you're going to know why you're taking each one of them. Now, my daddy, I had students to take care of my daddy before, and he would go the student would bring the pills into his room. He would pour the pills in his hand and he would start questioning the student. Now, what pill is this for, and why am I getting this? And he knew every medication that he was on, and if you gave him something different, because sometimes, and this happens a lot of times, the patients their pills are different color at home, and they know it by colors, and he would go and say, well, I don't know what this drug is. This medication right here is, mine's yellow, and this one's blue, so you need to tell me what it is. And he would not take it. He would actually show him the containers to make sure that it was the same drug that he was on in the same milligram. And that was just something that he was very which I love to see patients that know about their medications.
Most common.
If they don't, I'm just taking this.
Just a little funny. I had a lady tell me one day, I asked her what kind of medication she was on, and she said, well, I take a peanut butter ball every morning. Peanut butter ball.
Oh.
Peanut butter ball.
But you know what? That's how she remembered it.
Yeah, it was a peanut butter ball.
And then you can relate that to how she remembered it. Love it. Love it, love it, love it. All right, okay. Let's see. All right, now this is what Robin was asking me a while ago. On some of the little funny things that I've sent y'all, it has several names on the drug. That's probably one of the hardest things to do. Because there's so many, I don't know why in the world we just can't name it one thing. But no, we've got to have a chemical name, and we've got to have a trade name, and we've got to have a generic name. We've got to have all these different names, and it's the same drug. So as a nurse, we are going to have to realize or actually know the different names. The only name that you do not, well, I won't say that. There is one chemical name that a medication will be listed as, the same medication. You're more, well, I will say this. You're more concerned about the generic and the trade name. As a nurse, those are the two that you're going to be more familiar with as you begin your practice, when you start seeing medications. Now, I will tell you that anytime you have a medication on a test, I know that's where y'all's brains go all the time, testing. On a test, you will have both the generic and the trade name available for you. The NCLEX will give you the trade name and the generic name for you. So if you didn't memorize both names of them, at least if you memorized one of them, they'll click out to you. And so we will provide that information for you. Okay, so you will have both names, and you will have both names throughout this whole nursing school. So once you get used to it with here, then we're gonna, it'll be easier for you throughout the whole process. Now, as we start, the generic name's easy, trade names by the company. When we start into the classifications, and I don't want to go there yet, there are lots of suffixes and prefixes of medications. When you see like a pril that has PRIL at the end, then that's going to be a click to you to what type of medication that is. Okay? So once we get to those, we're going to, and that is going to be an easier way. When I said to you, memorize or learn the classifications, there's going to be little tricks that you can, that I'm going to teach you, that you can look every time you see PRIL, then you're going to know what classification this medication is, and you're going to immediately start thinking, oh, that's a whatever. I need to get going in and knowing what an ACE inhibitor is. Okay? So those kind of, if you'll take all those little tricks, thank you, it'll help you start learning the medications a whole lot better. Amoxicillin drugs, right? Amoxicillin drugs, prils, LOLs. Not laugh out loud. But LOL is one of them. So there's going to be little tricks that I'm going to help you if you'll just listen. And I will have to tell y'all this. I had one of our students, we were here this weekend, in clinical. She was one of my students probably 2 or 3 years ago. She came in and sat in pre-conference with us. And I said, after I saw her the next day, I said, is there anything you needed to tell the students? You came in there and said, she said she just missed me. She wanted to sit in there with us. And so she said one of the biggest things I would tell people is to listen to what y'all are saying. She said, I would give anything if I would have listened like I should have listened while I was in nursing school. And I said, well, maybe you need to go talk to them and tell them the little things that I say to you up here will build throughout your whole, and when I say to you, I need you to know this, there's a reason why you're going to have that information and you're going to build on it. The same thing with classifications. Every drug that you see that ends in pril, you're going to know that's an ACE inhibitor. Every drug that ends in LOL, you're going to know what it is. Okay? So those are the kind of things that I want you to listen to me. I'll help you if you'll listen. Okay. So those are the three names that we've got. Now, medication and or do I need have any questions before I go on? Because I'm going pretty quickly. I feel like. All right. You want to have some legal issues? You mess up with medications. This is a major legality here. Okay. We have got to know what our scope of practice is when we are administering medications. There are many different routes. Do you know what I mean by routes? Ways to give drugs. As a nurse, I can only give drugs a certain way or by certain routes, like by mouth, which is, you know, the term PO or oral, by subcutaneous, that's an injection, that's going where? Subcutaneous tissue, intramuscular, going in the muscle, intravenously goes into the vein. Can I do intrathecal? That's going into the spine. That is beyond my scope of practice. You have to know how you can administer and what you can administer per route. If you have a physician that comes up and says, I need you to give this through his epidural. No. You are not trained at this point to administer medications through an epidural. Okay? You have to know your scope of practice. Okay? And stand up. There's a lot of people that get in a lot of trouble because they practice outside their scope. You've got to be up on that and know what you can give and what you cannot give. You know that you are responsible for your own mess up or your own action, okay? If you make a medication error, you need to own up to it, okay? And I had a nurse that worked with me. I worked in labor and delivery. Our standing order was pretty much Stadol 1 milligram when a patient came in labor. Stadol comes in 2 milligrams in an ampule. The nurse drew up the whole dosage and gave the whole dose to the patient. Didn't hurt her, but that's not the order. And what she did was, instead of admitting that she gave the wrong, because I have never, knock on wood, had a medication error in the 25 years I've been doing this. Never. Because I am so anal about checking meds and doing stuff, and I've been like this since I started practicing. But anyway, instead of us saying, I made a mistake, I gave 2 milligrams as opposed to 1 milligram, she went and changed the doctor's order. Oh. Yeah. She just went, it had written Stadol 1 milligram IV push, and she went and marked out the 1 and put a 2. That is not, she's now no longer an RN. Okay? You cannot do things like that. If you make you're going to make a mistake. Okay? You're going, and the only reason I haven't made a mistake, I think, is because I am so anal. It's not that I'm perfect. I mean, y'all know I'm perfect, but, you know, everything I say is right, and, you know, just, but anyway. I think I am just so anal about it. And I hope if I can't give you anything else, I hope you become anal about it too. You know, because it's some serious business. It's serious. When you begin to get orders and when you start looking at the medications, and we'll talk about orders in just a little bit, at every order you look at, you need to make sure that every part of that order is there. If there's anything that looks questionable to you, you don't, you know, it just doesn't look right, you need to clarify. And you need to call that physician. Or, for instance, I think one of the biggest things that I have trouble with as a nurse and doing medications is I can't always remember the dosage range for every medicine. And that's going to be another thing that you're going to be required to know. Is that range that you can give somebody in 24 hours acceptable? Is it okay to give them this much medicine? That is where I'm deficit at. And I know that I'm deficit at. So when I see a drug, I always go look up and I'll think, you know what? I'm not sure if this dosage is the right dosage. Where do I go? I go right to my drug book. Because I can't remember every range of every drug. It just maybe, I think, you know, God, that really don't look right to me. It looks like it's too much. So whose responsibility is it if you see a drug written and the dosage range is too much to be administered to that patient? What are you going to do? Give it because the doctor ordered it. No. You are going to call that doctor and say, look, first of all, what I do is I usually call the pharmacy and say, am I reading this correctly? Is this the right dosage? You know, I mean, I'm just like, I sort of have enough, so I'll have some more evidence. So when I call the physician and say, hey, Dr. Jones, I see where you've ordered 50 milligrams of lisinopril for this patient. It is recommended 10 to 20. I'm just wanting to verify that this is the right dosage that you wanted to prescribe. Okay? So you're not going to give anything. Once you take that pill to that, or that medication to that patient, and you give it, you are responsible. And you have a legal issue if you administer a medication out of that range that's too much or too less. It is your responsibility, so you have to be accountable for what you gave. Okay? It's okay if it takes you a little bit of time to get that range. I don't know it myself. But please don't get lazy and say, well, the doctor wrote this. He knows best. He knows how much the dosage needs to be. You check for yourself. I will tell you, every week when you go to clinical and you get your list of medications, on that medication sheet, it is a sheet that, it is an area that says dosage range. You are to look up every drug and the range that can be given to a patient and make sure that that drug is within an acceptable range. Because you know what? I'm going to ask you. I'm going to say to you, Whitley, is your medications within the normal range? Yes, ma'am, I have looked them all up. Do I want Whitley to tell me her 25 meds in every range of every drug? No, I do not. Do I know them by heart? Heck, fire, no. Am I going to expect you to know them? Heck, fire, no. What I am expecting Whitley to do, though, is for her to have checked every one of them to make sure that that range is acceptable so she can make sure she's giving the right dosage to that patient. Okay? So I'm not going to make you memorize them, but I am expecting you to look at it, because if it's out of range, I will not give it until I have verified myself that the range is out of whack. I have contacted the physician and let him know, because I ain't losing my license for nobody. Okay? But the other thing is, I'm not going to give a patient too much medication or not enough medication. Because as a nurse, I'm supposed to do interventions that help my patient, not hurt them.
So if the doctor said, yes, that's what I want to give them, and it's outside of the range, and you tell them, can you actually tell the doctor that, no, I'm not going to give
Yes,
that?
you can. I will not be administering that medication to the patient.
We can actually do that?
Yes, you can.
Will he
Yes.
come and give it, or they just?
If he wants it to be administered, then he goes right ahead.
If it's out of the range like that, you call him and he says, yes, I still want you to do that. At that point, I mean, if the doctor says double check yes, then
Okay.
should you, or?
Then I say to him, I don't feel comfortable giving that medication. Then I will report this to my charge nurse, and my charge nurse can deal with it. But I will not give it if I have evidence
That it's out of the range?
that it's out of the range.
What if he says like it's a one-time thing, even then?
I have to stick to my guns. It's about that patient. I will give you a prime example, and this happened to me. I was working labor and delivery. I had a lady who came in and she was inducing her labor. We have specific parameters that says you are not to increase the medicine if the patient has contractions over this. So I had a guideline. It said, if you're doing this right here, then I don't go up on it. Well, my patient was having contractions every 2 minutes. They were lasting 60 to 70 seconds. Ooh. The Pitocin, yeah, like him kind. The Pitocin, I did not increase anymore. So, and it was getting late. I was working third shift, I think. And so I called the physician just to give him an update, because it was about 10:30 and I knew that I needed him to not plan on getting a good night's sleep, because we were going to have a baby. So I just called him and gave him an update, and he said to me, increase the pit. I said, sir, I am following the protocol. This is what I have got. This is what my patient's doing. I will not increase the Pitocin. Well, you go get somebody else to do it. I said, sir, I'm responsible for this patient. I am not going to give. Well, let me talk to the charge nurse. Okay, that would be fine. I gave the phone to the charge nurse. What does she do?
Hopefully she backed you.
No, she did not back me. She did it anyway. Within maybe 25 to 30 seconds of her increasing that Pitocin, the patient had what we call a Titanic contraction that lasted 90 seconds, where her uterus was not relaxing. And when you have that happen, your nursing intervention is to turn off the pit. So if she would have backed me, that wouldn't have happened to that patient. So you've got to stand up for what you believe in. And if you've got proof, I was not increasing that medication, because that medication had a therapeutic range. It had done what it was supposed to do. He just wanted a baby quick so he could go to sleep. I don't care if you ever get sleep. You know what I'm saying? That's what I wanted to tell him. I don't care if you ever get sleep. You are making the big bucks. You get your honey whitey in here at 3 o'clock just like I am, and we're going to have a healthy baby. Okay? You've got to learn how to stand up. But you got to have proof. I had the proof. I had the protocol. This is what it said. I'm supposed to not go up on that pit anymore, because this is what I'm following.
Just thinking about the whole patient advocate thing, would you tell the patient that they're trying to do something that shouldn't be test? No. But what if it's something that would cause them harm? I mean, I would want to know as a patient that they're trying to do something that's not okay.
They don't need it. Because I am advocate. I'm not an advocate for her.
back.
But she got this anyways.
Yeah, she did. But I didn't do it. Oh, I see what you're saying.
I mean, so she, I mean, the patient is the one that had this consent, whatever, and she's
Right.
the one that might have.
And no, I did not
And
tell her.
As a patient, I would want
I mean, I'm pretty sure that she was understanding or couldn't understand why I had now stepped over and another nurse came in. I mean, I was still in there with her. I was still, her nurse, but I was not going to give that medication. And I see what you're saying. No, I did not tell the patient, and I'm probably not going to tell the patient at that point because that's opened up a can of worms.
Now, if that would have caused problems within the baby, then they would have been held for the charge nurse, not on you,
Not on me.
correct?
Because I actually did everything I was supposed to do. I refused to give the medication to the physician himself. I documented. I refused to give that. I reported off to my charge nurse. She's accountable, not me.
You document it in your records and everything else in there?
Guidelines.
There's guidelines for a reason.
I had an order like that last spring.
You had a what?
An order like that last spring,
Mhm.
and it was blood pressure med. And every time I checked the ankle pulse, it was like 57,
Uh-huh.
58, around in there. And it was the hold if it was less than 60.
Right.
So I told her, I said, I don't feel comfortable giving her med.
Right, you shouldn't have.
And her orders, you're not supposed to. But the nurse on the floor was insistent about giving it. And she was behind me and checked it. Oh, it's 61, 62. And she checked it. And I was like, well, I'm not giving it.
Good girl.
But the instructor backed me on it, but she was still insistent on giving it.
Yeah.
So I don't know.
But it's not on you. It's not on you. And there's times that you gotta really go fight to your charge. I mean, not really fight, but fight for your patient. Well, yeah, fight for your patient. Because that patient deserves the care that they need to get and nothing, you gotta stand. What Deanna was saying is she had a patient whose the medication was not supposed to be given if the heart rate was less than 60. When she checked it, it was 52. What did she do? I'm not giving it. Okay? But she didn't give it. The staff nurse went and checked the pulse again. She said it was okay, so she gave it. Okay? So she's responsible, but not me. So you've got to learn how to stand up and say, I don't feel comfortable giving this. There's a lot of medications that's going to give you some parameters. That is why I have you check the doctor's orders. Because it's going to say in there a lot of times, do not give if it's this. Do not do if it's this. Okay? And you got to follow that. But you also got to follow your drug book. And your drug book's going to tell you, you need to take that apical pulse. So before you administer that medication, you better check that apical pulse. And I'll talk about that in just a minute. Right, but it doesn't stop there. What'll happen is the staff nurse that's taken care of has refused. She's reported chain of command. I've gone up to my charge nurse. My charge nurse refuses to give it as well. She goes to her director. The director, and it can go all the way to the chief of staff. All the way up there. But you've got to have evidence. It ain't just going to be like, I don't want to get this because I need to go eat my breakfast. Okay? Now, you got to have some evidence of why you're not going to get it. I can't physically, how do you want to physically take her down? Do like I do my son and get his ear and do like this? Now, I don't have to follow my training plan. Yes, I am an advocate for that. I can say, I strongly believe in this, but I can't make somebody else not follow the rules. You see what I'm saying? So, it gets sticky a lot of times, especially if you are very adamant and you got lots of information to prove that you don't need to be doing this to this patient. So just stick your ground. Be mean. Just have enough guts to say I'm not going to do it. All right. Any questions about that? And we'll talk more about that as it goes on. Or as we go on. All right. We'll go over the process of, my back's hurting, y'all. Is it okay if I sit down? This is what you call a 50-year-old woman. Okay. Can y'all see me? Or y'all want me to stand over there at the computer and not look at you? Okay. That was ugly, wasn't it? Ugly. Okay, I'm being ugly now. I was sweet a while ago, I'm ugly now. Alright, so I will go over the different types of medication, where medications are kept with you later. Okay? But I did want to let you realize that there's some medications that can't be out in open bins. Okay? Our narcotics, our controlled substances that, and now, this is not just a drug that I said, okay, I need to lock up my Dilaudid. It is mandated by the Board of Nursing, and it's also mandated by pharmacy. So there are certain medications that have to be under lock and key at all times. There is a specific form and a specific way that you have to sign out for those medications. Okay? As a nurse, as a student, you will not actually be signing off. I can't sit down and teach. You won't be yourself signing off for any controlled substances because it has to have 2 RNs to sign off of it. So you will be with me doing the process, but I will be that RN signing with another RN. I.e., let's say my patient's got morphine ordered. That is a controlled substance. I have to go through the process of going and get in the locked area and pull out the medication. Well, when I pulled it out, the doctor ordered 2 milligrams, but it has 4 in it. Okay? I have to discard the other 2 and waste it with another RN. It has to be witnessed by another RN. I can't just go up and say, me and Hope's over here, we're in our little room and we're doing our meds and we see we need to waste, and I'm going to squirt the 2 milligrams down the sink, and then I'm going to go out and tell Jennifer, oh, by the way, I wasted 2 milligrams of morphine. Can you sign for me? No. You don't ever do that unless you've seen it with your own pupils. Okay? There are plenty people, and I hate to say this, but there are plenty nurses that take that 2 milligrams and shoot it under their fingernails, shoot it under their toenails, shoot it in their veins. I am not going to witness something that I do not see with my own eyes. Okay? When you go in there, you are actually signing that you saw that person get rid of that drug, because it is controlling every controlled drug, every dosage, every drop of every controlled drug has to be accounted for. Okay? And at the end of the shift, they will do a count. They will make sure that the numbers are matching. So whatever was there when we started the shift better be there, everything accounted for at the end of the shift. You have to make sure that all of those numbers match, because if they don't start matching, then they're going to be coming and seeing. They're going to see if you just forgot. There have been times that when I worked third shift, I left and went home, and I had forgotten to sign out for a narcotic. And I'd have to get my little sleepy behind up and drive all the way back to the hospital and sign out for the medication because I didn't sign it before I left. Okay? It is serious business. It's everything has to be accounted for. All right, do y'all need a break? 10 minutes? All right. 10 minutes, then we'll keep going. All right, there are certain types of things that we want to happen when we give somebody a medication. We talked about the therapeutic a little bit, but that, and I told you a while ago, when you give a medication to someone, I'm going to ask you, why are they getting it? So the therapeutic effect is the reason why we are going to give this medication to someone. This is what we want to see happen. Does it always happen?
No.
No, it does not. But we can keep trying, can't we? We can keep trying. The side effect, that is something else that you are going to have to tell us when you are communicating with this. What type of side effect, excuse me, that may occur as a result of me giving this medication to someone. Now, side effects are not always bad, okay? It could be either harmless or it could be harmful. But when you look in your drug book and it has the medication, it has side effects, those are the kinds of things that I'm going to ask you, what are you looking for? Because if I give this drug, a side effect may happen with the patient. I need to know if it's related to that drug. Just like we were talking about a while ago when Jeff said, well, what if they're on Kudel's a Med? How do we know what side effect is coming from each drug? Well, when they're on 25, it's going to be hard for us to decide. But at least we know that if you're going to administer this drug with this patient, you're going to know why he's getting it, and you're going to know what types of side effects are you going to look for when you administer that medication to that patient. 9 times out of 10, it's going to say nausea, vomiting, and diarrhea. I don't want to hear nausea, vomiting, diarrhea. Okay? That is just a side effect that happens with almost every drug. What I want to see are things like Lasix. It's a diuretic. It's going to get rid of that volume, that plasma volume. Okay? One of the side effects of Lasix is when you pull a bunch of fluid off, what else goes with it? Electrolytes. Which one? Potassium. So as a result of giving Lasix to somebody, it's going to decrease that fluid, and then as they're pee-peeing out, the potassium is going to go flying out in their pee-pee. So that decreases the potassium level, so you know that's a side effect. Can that be harmless?
Yes.
No.
It could be harmless if it just brings it down a little bit, but it could be very harmful, because what happens when you've got decreased potassium? What muscle's affected? The heart. So if I don't have enough potassium, is my heart going to be able to contract? So then my patient may have a heart attack as a result of the drug that I just gave him. Okay? So it can be serious. It's something. And I can tell every one of you right this moment, when you give a Lasix, you better know that potassium level. I'm telling you, right up front. Because that can be some serious business. Our patients can go and have anywhere from having an irregular heart rate to their heart stopping as a result of potassium being too high or too low.
So what if we have somebody that's on Lasix and they have not drawn a blood level of potassium?
And if they haven't,
You don't get
then you just call right up there and say, Dr. Jones, this patient is getting 80 milligrams of Lasix. Can I get a potassium level on him? Get that order. Because you're going to have people, because Lasix does that, you need to have a baseline of what it is prior to you giving it. Okay, so 9 times out of 10, the physician's going to have already ordered a CBC with electrolytes to see what they are before you give them something like that. Because you got to know what it started from. Because what if his potassium level was low to begin with, and then he's ordered 60 milligrams of Lasix? We know that Lasix pulls potassium out. Would I want to give him Lasix if his potassium level's already?
No.
So that would be something I would report to the physician, because there are other diuretics that do the same thing, but they leave potassium alone. Okay? So that, knowing that that is a Lasix depletes potassium, and my patient's already got a low potassium, and I see that, that would be something I would call the physician and say, hey, this is what's going on. His potassium's 3. Do you want him to have this 80 milligrams of Lasix, or would you like to order another diuretic? Oh, sure, I'll be glad to order Bumix. Okay? But if you don't know about that medication and know about what things that can happen, then you're not going to be able to communicate with him and know something's wrong. Scared? Medication administration scare you? Sure. Should. Scares me too. Been doing it for a long time. Scares me to death. Because I want to make sure that I'm not doing any damage to my patient. Adverse effect. Those are basically a more severe side effect that could really be more damaging, i.e. the Lasix. If that potassium, if I had given him that that Lasix, and I had saw that he depleted the potassium level, that would be a severe adverse effect because it had gotten worse. It was a side effect that got worse, and that may warrant me to talk to the physician about pulling that drug away and let's get another drug. It does the same thing, but it may not have those type of effects. Okay? So that's a little bit more serious. Drug toxicity is never good. In other words, I've either given my patient too much medication and he can't get rid of it. He's not able to metabolize the medication at the dosage range that I gave him. So the reason why I told you to check that range was to make sure that it wasn't too much to be broken down and used in the right way and the way it needs to be. When they become toxic, you do not want to give that medicine. I'm going to give you an example. Theophylline is a medication for breathing. Okay? That drug can cause major toxicity side effects that can potentially be life-threatening. So what they do when a patient's on theophylline, they draw lab values. And they see that this lab value is within normal range, then I can give that theophylline. If it's not within normal range, you are to hold that drug. Okay? So there are many drugs that are like that you've got to see what happens or what the patient's signs and symptoms are before I ever give it. The same thing with digoxin. If the heart rate is 60 or less, I am not to give that level or that patient that medication because it can cause toxicity to the heart. One of the things that digoxin does is slows the heart rate down. Well, if I've got a heart rate of 52, how much slower do I want it? Do I want it to do that? Heck fire no. Don't give it because it can develop toxicity. Digoxin's another one that you're going to see them draw lab values for to make sure that that drug is within a therapeutic range, so I will not give him any more. It has to be. That is major. You have got, when you see a drug like theophylline or digoxin in your drug book, when you're looking it up and it says that that drug toxicity is very common, it's going to tell you the signs and symptoms of what the patient's going to be doing if they start becoming toxic. Okay? So if you didn't have a lab value and you went ahead and gave that patient that medicine, it's going to tell you things. Well, if they're dig toxicity, one of the first things that they're going to see is they're going to be very lethargic. So when you do your assessment, especially after you've administered the medication, you're going to be looking to see if the patient is lethargic. Do you see where I'm going with this? Okay? That is why it's so important for you to understand what you need, why your patient's getting it, what is it supposed to do, what kind of side effects am I looking for in that patient, and if they're risk for toxicity, what kind of signs and symptoms do I look for? Do you think those are the kind of questions we're going to ask you in clinical? Mm-hmm. So you're going to be aware of this. There's a reason why I'm asking you. I just didn't sit down one night and say, okay, let me just see what I can ask. I didn't. There's a reason. I want you to understand why you're giving this medication to this patient. What is it supposed to do? And if it's not doing what it's supposed to do and there's side effects happening, I need to know about those side effects because those side effects can get so bad that my patient may develop toxicity and die. And that is not what we're here for. Okay? So you got to be aware of every time you administer a medication to somebody, you got to know about the medicine and what it's doing and how can I know what to look for if something's going wrong. Does it make sense? All right, drug allergy. Now, how many times have you asked your patient, do they have any drug allergies? Every time. I can't remember which one of our patients, probably, was it your patient, that had like 14 allergies? Was it yours?
Any medicine that she wasn't on, she was allergic to.
Exactly. I mean, it was like the list went on and on and on. But it was a good thing that I knew that she was allergic to those things because I don't want to give it to her. But some people, when you ask them about their drug allergies, ask them what type of things happened with you when you took that medicine. Because it may just be I was a little nauseated. That's not an allergy. That's an intolerance. Like, how many people have ever taken an antibiotic and what do? You have diarrhea and you're nauseated, right? Does that mean that you can never take that medicine again? No, it just that you know that my stomach does not like this antibiotic. So if I take this antibiotic, I better have something on my stomach before I take it. But I'm not really having an allergy. An allergy is when my throat starts shutting up. I start developing a rash. Okay? That is an allergy. That's when my blood pressure starts going down and my pulse starts going up. It's almost like you're going into a shock situation because an allergy is saying, oh my gosh, there's something in my body that I do not like. And the first thing I'm going to do is I'm going to try to start fighting it off. Well, you know what? my body just wasn't strong enough to fight it off at that point. So I'm going to start closing my throat. I'm going to drop my pressure. I'm going to increase my pulse. I'm going to be itching everywhere. That is an allergy. So when you're talking to patients about, tell me what happens when you take this medicine.
That's therapeutic.
That is therapeutic communication. Do you think we communicate like that? But isn't it going to be better if you know exactly what happens to them? You know, I want to know, was this true allergy? Because I can tell you, if they say to me, Miss Walker, I took penicillin. My throat closed up, my blood pressure, they almost had to do a trach on me. I will not even let penicillin get anywhere near that patient for her to even smell it. Because why do I want to put her in a situation that could cause that to happen? So penicillin, I'm going to have a big old note on there, don't give her no penicillin. Because this is what happens. Whose responsibility is it to look to see what their allergies are, to see if the physician has ordered anything that they're allergic to? It is your responsibility. You need to keep up with those allergies, and because there's times that you'll go in there and the patient will, or the doctor have wrote all this stuff, and you look and say, oh my gosh, they're allergic to this. And the doctor has ordered this. Are you going to give it? No. But if you don't have that knowledge of what their allergies are, you're going to be going to give a lot of medications that you don't know what you're doing to that patient. Killing patients is not one that I want to do. Have you ever heard of the term anaphylactic shock? That's what was anaphylactic shock. The throat closing, the blood pressure, that is something that you're going to see. Well, let me just ask you this. What is the most common classification of drugs that you see anaphylactic shock with? All right, you give it a high five back here. Let me hear it.
Epinephrine.
Or what classification is that?
Cylinders.
It's a cylindrous drug, but it is a antibiotics. Not just the cylindrous, but all antibiotics can cause anaphylactic shock. So every time you give someone an antibiotic, you better be looking for this. Now, does that mean the first time I'll give them the first one, I'm going to assess for anaphylactic shock, they didn't have it, you're going to be good? No. Because it can happen during the process of that 7 to 14 day, 10 day process that we're giving it to them. It might be the 4th day that we gave that antibiotic to them, and then all of a sudden they start closing up on me and start going into shock. Okay? So every time, the moral of the story is, just because they haven't reacted before doesn't mean I'm not going to assess for it, because every time I give an antibiotic, I'm going to assess for anaphylactic shock. Okay? Every time. Every time. All right. I'm not going through that. We know about this. Okay, I'm going to go through this, and this is going to be the last thing I do today.
And even when it is on the patient's chart, the doctor will still write it.
Oh, yeah.
Allergic to penicillin, and so many times they'll still write a prescription out. I'm like, yeah, they don't tell them.
Right, and that's what our responsibility is, to make sure that we know. When I first started nursing school, and when I first started nursing, we didn't talk that much. We talked about allergies, but not like major. And I think it's because now so many people, because antibiotics are the ones that you usually see it with, everybody was treated with antibiotics a long time ago, and now nothing works anymore. So we've been given so many antibiotics. When I first started, we didn't give people a lot of, we did, but they didn't have reactions to it. So it's really weird. All right. this is called pharmacokinetics. If I can spit it out. The biggest thing that I want you to understand with this is that how the body responds to the medication. Because once you start giving a drug and you start looking at the action, it's going to tell you where in the body this drug is broken down. What part of my body is breaking down this drug? And when it breaks down this drug, what does it do with it? So there are actually 4 different areas or 4 stages of the pharmacokinetics. And you need to know which one of these does what. There's a moral to my story. Okay? So let me just tell you the 4 different stages, and the stages, and then we'll talk about what happens with them. Obviously, if we give a patient something by mouth, it's got to hit the stomach first. So the stomach is going to be where our absorption. Do you know what I mean when I say absorption? Huh?
It's going to be taken in.
It's going to be taken in. So all that stuff, all that drug, all that chemical that's supposed to be helping me with whatever my problem is going to get to the stomach, and the stomach's going to start breaking it down and pulling it into the stomach. Then it'll go down into the small intestines, and it'll start absorbing there. As it absorbs here and goes into the small intestines, it has pulled out what it needs in the intestines, and then it's going to start shooting it to the bloodstream. And as we shoot the good stuff, this helping me treat whatever's going on, I'm going to treat it and throw it into the bloodstream. So when it gets to the bloodstream, it distributes it out to everything. So I can, for instance, if I'm taking something for my heart, I take it by mouth, it gets to the stomach. The chemicals that I need for my heart are going to go to the bloodstream, and that's it's going to be distributed, it's going to go straight to my heart, to where it needs to do what it needs to do. So my heart's going to say, come on in, I'm ready to get better because you're finally here. This chemical's finally here to help with my heart. So as we work there, it then has to go, after it's distributed out, it goes to the liver. And what happens in the liver is it starts breaking it down and metabolizing it. So the 3rd phase is metabolism. So that liver is help breaking down everything and metabolizing it. And what do you think it's doing? Pulling what out? What it needs. And what it don't need. So as it breaks down the stuff that I don't really need in there, it's gonna go back into the bloodstream, and if I don't need it anymore, where does it need to go? It needs to go to the kidneys, because the kidneys is the ones who take it all out and get rid of it, right? So there's 4 different phases that you can go through. I don't expect y'all to know that. We talked about the absorption. Oh, wait a minute, I skipped one. No, I didn't. Okay. We talked about the absorption. Let me just go back and say this. So if you know that the stomach, the bloodstream, the liver, and the kidneys are all working together to help get a medication and the medication work like it needs to, right? So we know that we got to think about it. Your body is a team. our organs all work together. So all those organs are best friends. Okay? When you have a deficit with someone in their liver, you have to look at the whole process of medication breakdown. Because what does the liver do? It breaks it down and it helps metabolize everything. So what if somebody's got a liver problem? They can't break it, so it's going to accumulate. So if it's not breaking down good, what would you think patients would exhibit when I gave them, let's say I gave them IV morphine, and they've got liver issues?
Drug toxicity.
What do you think is going to happen? What's going to happen with them? Because I really want them to absorb it, metabolize, distribute it out, metabolize it, and excrete what they don't need. So if they've got a liver problem, what do you think is going to happen with that morphine?
It may not work.
Just stay in the body.
Lots of talking. So, liver problem, we got morphine, so the morphine's going to sit there.
Toxicity.
And there's a maybe that my patient sits there and hangs on to that morphine, and hangs on to the morphine, and hangs on to the morphine because the liver's taking a longer time to metabolize it. So the effects of the medication might be what? It might be slower and it may last longer because I can't get rid of it because I've got a liver problem. So you've got to take into consideration when you give somebody a medication, you got to think, does all the organs in the phases of this work so the medication can do what it needs to do? So let's say we know my patient has a diseased liver. What kind of things would you see happening or expect to happen when your physician writes an order for like a pain medicine?
Take longer to take the enzyme.
Well,
Stay in this longer than
it's going to stay in their system longer. I mean, I'm liking y'all talking. I'm liking this. But if it's a diseased liver and it can't break down, you may actually see them have a smaller dosage because they can't metabolize them. Or if we give them the regular dose, it's going to take a long time to get that dosage out of them to PP it out. For instance, pain medicine, like people that come out of surgery, they're the prime ones. When we give them medicine, it takes them a long time to get rid of it, especially if they have problems with their kidneys or problems with their liver. So when you look at that patient holistically, you got to make sure they got adequate, especially when you're giving them a bunch of drugs. You want to make sure that every one of these phases are working so the medication can work correctly. Does that make sense? So if I gave somebody 8 milligrams of morphine, we'll give them a lot. And what would I expect them to do? I expect them to be groggy, right? Hopefully the pain would be gone. The breathing might be slowed down a little bit. Heart rate they might be cooled out. But the pain really is what I wanted to get rid of, right? But then as I watch them, I would expect them to start being more alert, right? Coming around a little more, maybe hurting a little bit more, maybe an hour and a half later. because I can see the drug doing what it needs to be doing, the liver breaking it down and the kidneys getting rid of it. But if they don't have adequate liver function and kidney function, the side effects of the medication are going to be drawn out. It's going to take them longer to start waking up. It's going to take them longer to get rid of that medication. So it's vital to know there's some medications that say you can't give this medicine if they have the kidney function. All right, my group, what do you look for with kidneys? What lab values do you look for with kidneys? Creatinine and BUN. Thank you, Melon. Thank you. My group, where y'all at? We talked about that yesterday. I know, I'm going to get them. So if I have a patient who has a elevated BUN and an elevated creatinine, that means that my patient's kidneys are not good and functional. So do I want to give them a drug that says this could cause damage to the kidneys? So that is your responsibility to look at what could happen with this drug if I give it to them. And I got to make sure they've got adequate stomach problems or issues with their stomach, because that's going to absorb it, right? What about, and what else absorbs? Not just the stomach, the small intestines, right? And then what happens to it? So I want to make sure that it's got good transport over to the bloodstream and it's just distributed out everywhere. Then where does it go? To my liver. And my liver does what? It metabolizes it, breaks it down, and then where do we take it? To my kidneys, and my kidneys do what? Flush back. You got it. You got it. Woo-hoo! Any issues with the functioning of the stomach, the functioning of the liver, and the functioning of the kidneys? Okay? Now I got to share with you guys, because I share it with my group. When you're looking, because kidney function is vital with medication administration. I've got to see that they can pull all those toxins out. How do you know that my patient has adequate kidney function? My group. Labs. What kind of labs? Are you in my group? Okay, be quiet. Are you in my group?
You want your group to be quiet?
I want my group to be quiet. You go, girl. Who told you that? All right, so lab work. Have y'all looked at lab work this week? No. And not required to do that. But now when we're going to be giving medications, don't you think it's going to be important that we know that the patient has adequate kidney function? So I'm going to check the creatinine and BUN. Those are two lab values that you've got to know to make sure that you've got adequate kidney function. Okay? When you go into the hospital from now on, look at those labs and see all these medicines that we're giving somebody, are they able to do everything that needs to be done to get rid of the toxins? What other body function or organ helps us in breaking down meds? The liver. Does anybody know what labs you're going to look at to see if, my group, I don't think this is. So y'all think you can answer it.
Your liver enzymes.
Liver enzymes or liver function test, which is going to be what?
ALT.
Hepatic function test is the same thing, exactly. Who said that?
I see.
ALTs and ASTs. Okay, those are lab values that is going to tell you when you start looking for medication, do they have adequate function of that liver to break down the medication? Okay, so that's something that you're going to be looking at when you start administering medication. Got that? Are you ever going to remember that? Yes, you are always going to remember that. Ever going to remember that. I want you to remember those kind of things. That's when you start looking at the patient holistically and you start figuring out what's going on with them and making sure that they can break down those meds like they need to. Another thing as far as kidney function, I'm going back to the kidney now. Wow, I forgot this a while ago. What other functions are things that you need to make sure that are good and working good before you give that patient a bunch of meds? As far as, who said that? Output. How much output, not very be quiet, how much output do I need to make sure that that patient has an hour to verify that they've got adequate kidney function? Who said that? 30 milliliters an hour. I have to make sure that my patient is voiding at least 30 cc's an hour to let me know that they've got adequate kidney function. Do we go pee-pee every hour? Probably not. Well, I do. But, so most patients don't get up and go potty every hour. So when you're measuring that, you may get them to come up at 8 o'clock and they void 200 cc's. Okay? How am I going to know that's 30 cc's an hour? Go back and look
Last time they went.
the last time they voided, and then count how many hours it has been. If it's been 4 hours and they voided 200 cc's, I'm going to divide 4 into 200, and how much is that? How much? 50. Is that adequate kidney function?
Yes.
Good. So you've got to make sure that that patient's PP is at least 30 cc's. You can never, ever forget that. Okay, that is going to be something vital that we need to make sure that we know when we're dealing with medication administration and making sure they have adequate kidney function and adequate liver function. Because we understand the process of what happens when we give somebody medications, right? Through these phases. Got it? Woohoo! You'll never forget that, will you? All right, now, we talked a little bit about the different factors that affect patients' ability to absorb medications. Obviously, age is going to be one of the biggest things, and I don't even know if I got age up there. Woo! I need to put age up there, don't I? And the reason why, yeah, add age. A pretty important aspect that I need to be adding up there. Then the reason why I say age is look at how the range of people that we take care of. From birth to death. Okay? Do I want to give a newborn baby the same dosage that I would give a 65-year-old person? No. So I got to take into consideration how old they are. How am I going to better figure out how much medication my babies and stuff, my newborns, my toddlers, my 10-year-olds, how am I going to get a good idea of what how I need to make sure they've got a good dosage range?
By the weight.
Weight. You have got to look at the weight, because when they have a medication, when you look it up in the book, it'll say X amount of milligrams per kilogram of weight for that patient. So all pediatric medication is calculated on the weight. So you've got to know the weight of that patient, and then they're going to decide, do you think they're going to have poundage out there? It's not going to be pounds. It's going to be in kilograms. Well, how do I figure out what kilograms is? There are 2.2 pounds in 1 kilogram. So if I have 50 kilograms, I need to multiply that by 2.2. And that's going to tell me how many kilograms, how many pounds I've got. But if I've got, I meant to do it backwards, sorry. Let me back up. If I've got 24 kilograms, I want to do
I want to do 24 pounds.
I want to do 24 pounds.
Divided by.
And I would, okay, y'all confused me. Alright, y'all right, I'm wrong.
Yes.
Mark that. Mark it down because, and that won't happen again. Let me start over so I can get my little ADD brain back where it needs to go. I have 2.2 pounds per 1 kilogram. So if I want to find the pounds, and I've got the number of kilograms, I'm going to do what? Multiply. Ever how many kilograms times 2.2 to find the pounds. If I need to find the kilograms, I need to divide by 2.2. Okay. Is everybody with me? I don't want to confuse nobody like I just got confused myself. Okay, so you're understanding it. But what do we want to see? Because our drug book's going to tell us kilograms, right? So if we have the kilograms, wonderful. 9 times out of 10, we have the poundage, right? So if we have that pounds, we need to divide by 2.2 to figure out how many kilograms. Because in the drug book, it's going to say you give X amount of milligrams per kilogram. Okay? Y'all with me? Mm-hmm. Okay. Developmental, I guess we could really say developmental is sort of like age 2. Maybe that's what I was thinking. Okay, developmental stages are also, let me throw out my older patients. My little old ladies that weigh 89 pounds and have not one bit of muscle on their body, and they don't have good kidney function. When you're getting ready to administer medication to them, do you think Luke's going to say this is the dosage range that you can give them? Do you think it's going to be within that dosage range? What is it going to be? It's going to be lower. Okay? So because of their age, because of their decreased renal function, liver function, their dosage range may not be within the normal range. And you need to understand why the physician made a change in that because of the patient's condition. I can't give somebody, for instance, a lot of fluid, because that's something we administer, that's considered a medication. I can't give them a lot of fluid if they don't have kidney function. Can I? Because what's going to happen? It's all going to start backing up, and then they're going to have edema, and then where do you think the edema's going to go? To the heart, and then they're going to have congestive heart failure. What did you just do?
Critically thought.
You critically thought. What do nurses do?
Critically think.
What do I want you to do?
Critically think.
And you just did it. Okay? So every time you are giving a medication to someone, I need you to think through that process. What is this going to do for my patient? If I give them too much and they don't have adequate functioning, what's going to happen? Things are going to happen that I don't want to happen. So see why I want you to understand the process of medication administration and the absorption and the distribution and the metabolism of it and the excretion of it. So you can understand how I can get, when I give that patient that medication or those fluids, how is it going to handle, how is my patient going to handle that med? What are they going to do with it? Any questions? Because I'm getting some blank looks. Along with the sweats going down my back. I'm getting some blank looks. Are you following me? Yeah. Okay. Just want to make sure everybody was following. All right, so these are other things that are going to help. We talked about type illness. Another thing that you need to take into consideration when you're giving medication is the time it needs to be administered. Your physician's going to write in his order how many times a day you need to give this medication. Do you know what BID means? Twice a day. TID? 3 times a day. QID? 4 times a day. AC?
So that's morning, right?
AC. Before meals. Meals. Not before breakfast, because most people were thinking before breakfast. Meals. So time for AC would be before breakfast, which is around 7:30. Before lunch, which is around 11:30. Around supper, dinner, whatever, 5:30. Around 5:30. Okay? So do not forget when it says AC, you got to give it at all meals. There's a reason why they want it given at meals. Have you ever had a medication that you've been prescribed and it says take with food? Right, take with the insulin. It's one of the big ones. There's a reason. Do you think it has anything to do with absorption? So we got to understand the absorption. So you've got to when it says to be given those different, there's a reason why that medication has to be given that time. We are the ones that, in the hospital setting, and when we educate our patients when they go home, AC means, woo, give it to them right here with meals. Okay? I'm not really going to go in the time frames. I was going to, but I'm not going to do that right now. All right, see, diet is another issue that's going to affect it. And since Aaron mentioned insulin, I'm going to tell you right now, up front, when you're in the hospital setting, you will never give insulin until you have that patient's food on the floor in front of them. Okay? You are not going to give insulin, because we're going to learn more about insulin later and what it does, but you are not going to give insulin to anybody in the hospital setting until you have food right there. Do we know what insulin does? It drops the blood sugar, doesn't it? So let's say I go in and you know what, Miss Walker, it says that I'm supposed to give this insulin at 7:30. It is time to give it. I have to go get it. I'm going to administer it right now because it says at 7:30. But your patient is asleep. They haven't called down for their breakfast yet. Breakfast is not going to be here for another 45 minutes. So you go in there and you persist. I got to go give that medicine right now. You go in there and you give that medicine to that patient. His blood sugar was only 200. And you gave him 50 units. What's going going to happen to that patient's blood sugar? It's going to bottom out. So aren't we making something happen that don't need to happen? So we used a nursing judgment call on I don't have food right here, because if I give my patient insulin, it's going to bottom out that blood sugar. How can I prevent that from happening?
Wait for the food.
Wait for the food. So when you give it to them, they can start, you can give the insulin and they can start eating. And as they eat, it's going to help do what?
Absorb.
It's going to help absorb. Oh, goodness gracious. Absorb medications? It's going to start absorbing and distributing out into the system. And it's going to do what to the blood sugar? It's going to start balancing it out. Isn't that what I want to see happen for my patient? Okay. So there's a reason why. So nobody should ever give insulin without having food right there. Okay? Very, very important. So you can see all these other, well, let me just hit on culture real quick before I go on. What kind of situations would you see a culture or some type of value belief that someone has? Blood transfusions. That is the most common thing that you're going to see. You're going to see a patient who is a Jehovah's Witness. Do you know what Jehovah's Witnesses believe in? They don't believe in blood transfusions. Okay? They will not receive any blood products. But I have a patient whose hemoglobin is 4. What would be the treatment? A blood transfusion, right? They're Jehovah's Witness. They say no. Is there anything you can do about that situation? No, you cannot. As far as that order, you are not going to give them blood. What is other things I can do?
Increase their diet.
I can do diet.
Medication.
Iron. A lot of times you'll see Jehovah's Witnesses receiving iron intravenously. Okay? I can't be judgmental. That is their choice. Their choice. I cannot give them anything that they don't believe in. I can't push my beliefs on them. Okay? So that sort of gets as a nurse, you're like, I got to give them something, you know. But they don't believe that. And we can't go against their wishes. Okay? So you can see how many different things affect the way we actually give medications.
I was reading an article about Muslims in court about the flu mist, the live virus, having a pork product in the gelatin. Now they want to refuse it.
Yeah. Say that louder so everybody can hear you.
I was reading an article about the flu mist, the live virus has gelatin that's got the pork product in it, and the Muslims religious belief is no pork product, so now they're refusing that. Some of them are.
So we have to honor their wishes and honor what they believe in. It is very hard as a nurse to see a patient going through something that you know that could be corrected by a blood transfusion. It's very hard to sit back and know. So I got to look at other methods that I can do to help increase that blood volume or increase that. But don't go against someone's wishes. All right, so those are all the different factors that will affect medication and action. We need to know what we are doing or why we are giving, as a nurse, why we are giving certain medications. And I think we've pretty much talked about a lot of these things. You need to understand that drug administration is a nursing intervention. That is something that we are going to do. As you carried out some of your interventions this week in clinical and last week in clinical, remember we are doing things for our patient to help them meet our goal, right? I am sweating, y'all. Are y'all hot? I apologize, but I am sweating. So as a nurse, I need to make sure that I carry out and see that my intervention is working. Okay? So let's say we gave our patient an antihypertensive medication. What is that for? For high blood pressure. So I need to, as another intervention that goes along with me actually giving him or her the medication, I've got to assess to see if the action of what I wanted to happen happened. Does that make sense? That is part of your nursing process when you do an intervention, because we want to see if our interventions work. Right? So don't forget, as you carry out something, because drug administration is an intervention, you have to keep going with it. You also have to realize when you administer a medication that just giving them the pill and then assessing a blood pressure is not the only intervention you do when you give somebody medicine. There's a lot of stuff that goes along with giving somebody some medication. I've got to make sure that, first of all, I understand what's happening with this patient when I give it to them. I have to understand the effects that it's supposed to happen. Because if I don't understand what's happening with that drug, how can I teach my patient what kinds of things do they need to look for when I give them that medication? So it's going to be vital that I understand about the medication, what is a desired effect of it, what is a bad effect of it. So when I give it to them and these symptoms start happening, they're aware of what's happening. And they're educated enough to know, you know what, this might be a side effect or a bad effect of a medication that they just gave me. One of the most common ones that you'll see a lot of times that is really, really crazy, but it's just a very simple little side effect. Lisinopril. Has anybody ever heard of lisinopril? It's a blood pressure medication. You know what one of the side effects that people don't really take, one of the side effects that happens with them that they don't necessarily really think it's a side effect? Dry, happy cough. So it's like, oh my gosh, you know, they're not thinking, that's for my blood pressure. Why in the world am I getting a cough? So that is one of the side effects. That is what you need to teach them. These are the things that you need to look for. I'm giving you this, lisinopril. It is to lower your blood pressure, but these are some of the things that might happen. One of the common things is a dry, happy cough. Now, can you live with a dry, happy cough? Of course. Sure. Yeah, you can live with it. So don't go in there and say, you're going to die if you get a dry, happy cough. Just tell them that's one of the expected things to happen. If it happens, you'll be aware of it. If you can't tolerate it anymore, it gets on your ever-living nerve, then talk to your physician about maybe changing it to another blood pressure medicine. Okay? So you got to tell them all about that drug. All right, now let's talk about, or first of all, you have any questions? All right, wait a minute. Let me skip this one. Let's go to the next one, and then when we go to all the routes we'll do. I still don't like the order I got this in. I ain't got it like I want it yet. But anyway, let's skip this and we'll go through every one of those in just a little bit. Let's talk about order. I keep saying there's an order, there's an order, there's an order you got to look at. There are several different types of orders that you're going to get. And you have got to know how to respond when you get this order. One of the biggest, the most, well, I can't say most important. It's just important. Not the most. But if you look at the time frame you have, it needs to be done now. It's not one of those things that you can put off when it comes to organization. If your physician writes a stat order, yeah, I know y'all heard seen that all over the TV, stat. You know what stat means? Now. I ain't got time to wait. You got 5 minutes. Okay, or less. Get it there because something's going on with that patient that they need immediate attention. They need something done now. Do not wait. Now, when you get a stat order, it is only good for one time. So when that doctor gives you that stat order, you do it, and that order is no longer good. You have completed the whole steps of medication administration of that particular order. One time.
A question, and it's not really about a drug per se, but the person, the patient I had on the weekend, they had a stat order for a test for an MRCP, and it was canceled. So what is the length of time that a stat order for a test would be that they would have time to cancel it? Is that something that...
They canceled the test?
Yeah.
He wanted it done stat, and then now he...
Yeah.
As far as testing wise, they have a little bit more time. I think this is what you're asking me. They have a little bit more than 5 minutes. Okay, because then you've got to, get the patient down there. They have to go to another area in the hospital. It means that I've got at least 30 to 45 minutes. I got to have that done. Okay, so I would like for it to be, most of the time when they say statin, I mean now. I ain't going to be hilly hopping around here. I got to get down there. But it is a little bit different when it comes to testing and like an emergency situation. We need to get them in as quickly as possible.
They canceled that order, so I was just curious. She had cholecystitis. And so I couldn't find anywhere what they did instead or why they canceled it. So it's interesting.
I don't know. Sorry. Wish I could help you there.
The order's coming.
But stat, as far as medications, I need to give it now, like immediately. You may also get another order that they'll put at the end of the order now. You got a little bit more time with that one, but it needs to be given within 30 minutes. Okay? So the patient needs the medication or needs it now, but I can also not like lollygag around, but I've got 30 minutes. Now let me tell you, when you get an order stat or you get an order now, your first response is going to be, oh my God, oh my God, oh my God, I gotta go do that, I gotta go do it now. And sometimes you might forget that there are steps of medication administration that have to be followed. Do not get such in a tizzy that you don't follow the steps of medication administration. Okay, and I'm gonna drill that in your brain to no end in just a little bit. Okay, don't get so excited that you don't follow what you're supposed to do. Okay. All right. Let me just back up. Now order is one time. When that physician writes that order and he says now, after you have completed that administration, you no longer give, that order is no longer good. It is done. Mark it off your little schedule. Okay? Only give it once. Single order. Sometimes the physician may just write an order that he wants to be given one time. It's not a stat order. It's not a now order. He just wants it to be given one time. One of the most common ones that you're going to see is when a patient comes in and they have an electrolyte imbalance of potassium. Okay? Everybody knows what potassium is. If you don't know it, you better know it. Okay? Because you're going to be looking at patients' potassium level. I think we have one. Yeah. Liz's patient's potassium level was very low this week, and we had to give her potassium through her IV. And we kept monitoring it, kept monitoring it, kept monitoring it. But anyway, that was good. When we have a potassium order, the physician may come in and see that the potassium level is a little bit low, but it may not be low enough to do a big dosage. They may just need a little push or a little hump to get them a little bit more potassium. So he'll come in and write potassium 40 milliequivalents times 1. And that's your order, and you just give it one time. And it's done. You never give that same order again. All right. PRN orders. You know what PRN means? What do you think you're going to see a lot with PRN? What type of medication are you going to see PRN? Pain. Patients are going to begin. The physician is going to want this pain to be under control, but he's going to write it in a way that you can give it when your patient needs it. For example, he may say, give every 4 to 6 hours PRN. Okay, so he's going to write the drug, and he's going to tell you that you can give it every 4 to 6 hours PRN. You go in, your patient tells you, I'm in pain. What's the first thing you're going to do? Excuse me, you're going to do what? Assess the pain, right? Like pain scale, where's it at? Da 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 da. That's the first thing you're going to do, right?
Yes.
Then we can proceed. What do we need to do now?
Check order.
We need to go see the last time they had it. Another thing you may want to ask your patient is the medication that they gave you last, did it help? Okay? Because that's going to be a nursing judgment call on if it didn't help, then maybe I need to adjust the amount I give them. Because a lot of times the physician's going to write Demerol 25 to 50 milligrams Q 4 to 6 hours PRN. So I'm going to assess my patient. I'm going to look and see when the last time he had it. I want to see how he responded. Did it help? If he only got 25 milligrams 4 hours ago, I can still give him some now, right? Mm-hmm. But he told me that the 25 milligrams didn't help him.
So if he got it only 2 hours ago and he only got 25, could you give him another 25 within the 2 hours to equal the 50?
You've got to go, you got 25 to 50 every 4 hours. What you have to do in that situation is, if you gave him 25 milligrams 2 hours ago, he comes and tells you 2 hours that I'm hurting. That didn't help. Will my order cover every 2 hours?
No.
So what do I need to do?
Make it wait 2 hours.
I need to call the physician, because obviously the intervention that we did didn't work. So I need to call him and say, you know what? I gave Mr. whoever 25 milligrams of Demerol 2 hours ago. Your order says 25 to 50 every 4 hours. I can't give him any more at this moment. What would I expect? What kind of order would I expect to get at that time?
One time.
I can get a one-time order, right? So if he gives me a one-time order that says I guess I can hang up the phone. Still on the phone with him. He can give me a one-time order that says give him 25 of Demerol now, which will equal it, but I can't do it on my own because I didn't have an order that covered me every 2 hours. So I can get a one-time order. And what do you think he's going to do at that point? When he's seen, or we hope that he does, we've seen that it didn't work the 4 to 6 hours. Hopefully he's going, and then if he doesn't decide to change it, we can say before we hang up the phone, would you like for me to change the order to every 2 hours as opposed to every 4 to 6 hours? Sure, Miss Walker, that would be wonderful. I'm like I'm talking on the phone this morning. Okay, see where I'm coming? You can't go and get anything without having an order.
What about if, when you went in there the first time, he rated it like a 10, and you gave him 50, but then 4 hours later, and he rates it like a 5 or a 6, would you then drop it down to 25?
Sure. Nursing judgment call. Based on what?
Your order.
No, based on your assessment. Exactly. So you have to, there's a reason why we assess our patient and see how their pain is. Because I can make that, I've got the nursing judgment call, I can give him 25 or 50 every 4 to 6 hours. Depending on my assessment is how I'm going to decide what to give him. Okay, does that make sense? Wonderful. All right, question.
When you take a verbal order over the phone,
Mm-hmm.
doesn't the doctor have to sign off on it sooner?
He does. He has 24 hours. Okay. The one thing that's happening down at Northeast, which is wonderful, because we are humans beings, and sometimes orders get not transcribed correctly. So they are actually going in. It's better for them as a physician, when I call him, for him to get to a computer and him to put the order in himself. There's no transcribing it from me to you to here to here, I mean, it's just everywhere. So there's less chance of making a mistake if he just goes to the computer and puts it in himself. Now, if he wants me to do it, if he's driving down the road or something like that and he can't get to it, then he's going to stay on the phone with me while I go to the computer and I type it in and I keep repeating it to him verbatim. I do one word at a time. Okay? If he says to me Demerol, I'll say Demerol and then I'll put Demerol in. And then he'll say 25. Now, most times they'll go, Demerol 25 to 50 milligrams, just rambling right on. And I'll say, well, just a second. I'm typing it into the computer, and I'll do Demerol 25, Demerol 25, yes, to 50, to 50. I am repeating everything he says. And before I let him hang up, I am going to repeat the whole entire order to him, and I'm going to tell him this is exactly what I have in the computer. Because I want to make sure that I'm not giving or writing an order that is not what he prescribed. That is beyond my scope of practice. Okay? So yes, verbal order. There's some things that you may, some medications, which I'm not going to go into that right now, that you have to have 2 RNs listed while the physicians are getting the drug. Okay? It's a good question. All right. Other questions? I heard somebody didn't have questions. Okay, you with me with those? You have to follow exactly what the physician orders. Okay, exactly. Now, another thing that sort of gets y'all off a lot of times when you're looking at the medication is certain prescriptions, certain doctors and certain doctors' groups have a list of what they call standing orders. In other words, every patient that comes in with this particular group, they want these orders to be a part, so they don't have to write them or put them in the computer. every time. What kind of drugs do you, or what kind of meds do you think are going to be included in those kind of, that standing order? Something for nausea, because they don't want to be called at 3 o'clock in the morning because their patient's nauseated. What else? Tylenol. Something for a headache, because sometimes we get headaches in the hospital. So they don't want to be called at 3 o'clock in the morning. So they're going to go ahead and write the order for some Tylenol, or some for nausea, constipation, because they sure as heck don't want to be called at 3 o'clock in the morning when this little 90-year-old lady can't get her bowels to work. Okay? So they go ahead and write an order for a stool softener, and if the stool softener doesn't work, you can go ahead and give a flex enema, and it gives you certain guidelines over things that commonly happen when a patient comes into the hospital. Okay? But that's part of your preparation to see, do they have Tylenol ordered? Do they have a stool softener? Because I'm telling you, every time you go to the hospital, especially if you have an older person, they're going to be worried about their bowels. Okay? Their bowels cannot get locked up, is what they say. Okay? So it's very important. You know, bed rest makes you what? Constipated. So they're in bed. So I need to prevent that happening before. So if I see a patient that's going to be on bed rest, what do you think I'm going to encourage them to ask for or give them? Some type of stool softener. I know they're going to be locked up. Okay, I know they're going to have an increased risk of being constipated. I'm a constipated person too. I don't like it. So I know if I stay in the bed all the time, I'd never poop. So I know and how uncomfortable it is. I don't want to make them be any more uncomfortable. Okay? So those are the kinds of things that y'all don't want to know that kind of stuff about me, do you? So anyway, I know you got to think of how you would feel if you were in there. And you got lots of different orders that you can use. Now let me just tell you what will help you on prep day. Because you're going to have about 20 of these standing orders on your chart. Because every doctor has their own little thing. What you need to do on prep day is you need to look at that PRN list and look to see if any medication has been given in the last 24 hours. That's going to give you, because you're going to say, Ms. Walker, I can't look up all 20 of these PRN medications. So what I'm saying to you, look on that medication administration record that we're going to talk about in just a little bit. Look and see what has been given over in the last 24 hours, and I better know that. If you've been given a patient, or if your patient has gotten Demerol every 4 hours, don't you think you're probably going to have to give that Demerol over the 4 hours that we're there? And you're going to come to me and say, oh, I didn't look that up because it wasn't on my orders that I was supposed to give. No, you are going to look that up, and you are going to know what it is, and you're going to be able to come to me and say, Ms. Walker, my patient's in pain, and you're going to tell me your whole assessment of your pain, their pain, and we're going to make a nursing judgment call on what we need to do to help that patient get rid of that pain, based on when was the last time he had it, and based on our assessment. And then we're going to make a nursing judgment call on what we're going to do to help that problem. With me? Get a little nervous about making nursing judgment calls? A little bit? Yeah, I'm scared. But the thing of it is you have to be reassured. I'm going to ask you, tell me what you're going to do. And you tell me your plan. If I don't agree with it, then we're going to talk about it. Okay? We might have to find out a little bit more information. But the thing of it is you were thinking. And you were trying to get a plan to together. That's what I want to see. Don't stress out if your plan is not exactly correct. I don't care if it's not correct at first. I want to see you grow. I want you to say, this is what I would do. Here's my assessment. This is how I'm going to plan it out. Talk to me about it, and let's look and see. There may be reasons why I say, let's don't do this because of this reason. Okay? So I want you to come to me, come to us, and say, this is what I'm going to do. Be confident, and if you've done an accurate assessment, and you looked at your medications, and you got a plan, that's what I want to see. Then the next time, let's say if your plan didn't work, we'll work through it and we'll figure out what's going to be the best for that patient. But then the next time you do it, you're going to have a little bit more confidence in planning out your care. And you're going to go, let's say for instance, you didn't look at your patient's BUN and creatinine, and they have no kidney function. Their kidney function is just bad. But you want to give them 125 milligrams of Demerol. First of all, that's way out of the range. Second of all, he doesn't have adequate kidney function to be able to excrete all that. So we've got to look at another way. I'm not going to let you do anything dangerous to your patient. That is, if you communicate with me. If you don't communicate with me and you go and administer medication by yourself, that's a problem. You have got to communicate with us. You don't give anything, even think about giving anything without us checking it. I don't care even a Tylenol. Nothing. You do not give anything without me. Well, you're instructed. Okay? Please. Please. But I want you to think. I don't want you to come up to me and say, what should I do, Miss Lawford? And I'm going to say, you tell me. You're the nurse. Tell me. And it's okay if you're wrong. It's okay. I'm wrong just a few times.
Miss Owen.
Mark it down. Did y'all mark it down? Miss Lawford. I'll admit my error. All right, who needs a break? Let's see how long it takes y'all to get out to the road and smoke your cigarette.
Bless you, still got that cold. It's just once in a while. Well, that's good, so it's got a lot better. I got a schedule appointment with my internet connection. And I told Miss Barnes that I'm not worried about it.
You're talking about for Sims or for the med card?
For the med card.
What, you all? Oh, there you go.
Oh, yeah, it was done Monday. Yeah, I brought it to class. We were going to be class. And then my internet connection was down, and I sent her a message through my phone. I told her that I couldn't get work at work. On my phone.
I don't think so.
And I never did. So I guess lucky she's not going to be able to do it.
Man, here.
Let's start. Let's see what y'all did at him. What are we doing?
Oh, my computer's got it.
Let me go do my school.
I run behind you and follow you with my computer.
What you doing?
I'm going to ask you about the constant apps.
Oh, no, let me go do this first and let me get back. I gotta go potty and then I gotta go talk to Miss B.
Oh, so you was late.
Order. Okay, there are several different parts that you need to make sure that are there. First of all, you gotta get your patient's name. Okay? It'll be on the chart. You've always seen, everybody's seen your patient's name, so you need to make sure that you're in the right chart before you start verifying your orders. The date and the time that it was written is very important. The name of the drug that is going to be administered, the dosage, the frequency, the route, and the signature. An order is not complete if you don't have every one of these elements or items in the order. It is not correct. If you are missing one of those, then you cannot accept that order. Okay? There's really nothing else I can say about that. This is what it is.
If it's a call-in order from the doctor and it's not been signed, is that okay?
Yes, you can use that because it'll be either written down and signed off by an RN. And yes, but when you are, if you're the one taking the order, you need to verify the patient's name. Obviously, you know the time and the date that you got it. But all these, you need to have the drug, the dosage, the frequency, the route. And with him, I'm signing, and then I am signing his name. Because in my scope of practice, I can take a verbal order from the physician. If you are an RN. Now, if a physician will come up to you and want to give you a verbal order, you immediately, before he starts rambling off, you need to say, I am not a registered nurse. I cannot take a verbal order. Okay? When you are a registered nurse, you may take that verbal order. But you cannot as a student. So there should be no reason why you should be answering the phone up in clinical, because a lot of times what happens, when you answer that phone, there's a doctor and he's wanting to talk to a nurse to give him an order. Okay? You're not going to be doing that. Okay? So when you look at an order, you make sure that every one of these elements are in them. All right. Once the physician has put the order in, your computer your system at Northeast, I know, will generate what is called a MAR, Medication Administration Record. Okay? So the drug, the doctor is given the order, it is automatically put into the Medication Administration Record. This is what you are going to use as you administer medication to your patient. It may not always look like this, but it will be similar. Okay? But you can see it'll have the patient's name somewhere. It'll have the patient's name on there. It'll actually see when it was started. And if you look, I know you probably can't see, but a lot of you have, I don't think it probably came up good on what you printed out. But the first one says ferrous sulfate. That is the drug name, right? Isn't that what's one of the things that needs to be included? 300 milligrams per 5 mLs. 300 milligrams is the dosage. Don't worry about the 5 right this moment. Okay? 300 milligrams is the dosage. So I got the dosage there. Twice a day. That's the frequency. PO is the route. So do I have everything, and then the physician signed it, I promise you. Okay? So do we have everything that's making this order Correct. Okay? So this is what you're going to actually use as you do your order or check off your orders. Let me tell you what I have to have you do. When you have your MAR of the day that you are going to be given medications, I need you to take this MAR and verify each order with the doctor's orders, because doctor's orders is going to be somewhere else in the chart, right? He put the orders in. When you go on the computer, it tells you orders, right? And good old Northeast has theirs divided up into diet, activity, medications. So all you have to do is click on medications. It'll pull up every medication that's ordered for that patient. We will give you a copy of the MAR, and you will take this MAR and you will make sure that this MAR says exactly what the doctor's order says. You have to verify your MAR to make sure that it says the same thing. Now, the reason why I make you do that is because sometimes human error comes into effect. It's not as common as it used to be when the physicians came in and wrote their orders out. And then when they wrote their orders out, some human had to transcribe it. And then another person had to read it and make sure it was the right thing. So luckily, now we don't have to go through that process because it's generated right into the computer. But I still don't want you to get out of the habit to start off to see that this MAR says exactly what the doctor's order says. Okay? And depending on where you are, Northeast or Rowan, your instructor will show you how to do that in the hospital setting. But for check-off purposes here, I need you to understand that because you're not going to be able to verify your doctor's orders, so to speak, in this setting. But I need you to tell me I would verify my doctor's orders because I am making sure that the MAR says exactly what the doctor has ordered. With me? And you're going to verify your MAR with the doctor's orders. All right, I'm not doing this right now. We're going to Principles of Drug Administration. I think I have said this 150 times, right? What are you expected to know about this drug? Every drug that you are going to administer to your patient, you need to know what the drug is, the classification, what do we want to happen, what type of effects is it going to have on the body, is it contraindicated with anything going on with our patient, any type of side effects, or special considerations. What do I mean by special considerations?
Like the high blood pressure, or taking the blood pressure before you give them the medicine.
Exactly. You were just getting high fives today. What other was a special consideration that you better not ever do? You better have food right there, right? That's a special consideration. So you better need to know those types of things when it comes to medication administration. What are we going to ask you?
What does it have to be?
That. Those are the things that we're going to ask you when you get ready to administer medications. So you've been told what you need to tell me when you get ready to administer a medication. Wouldn't it be really, really nice for you and me too for you to come up to me and say, Miss Walker, I'm giving lisinopril. It is an antihypertensive medication. I have already checked the blood pressure. The blood pressure is this. And go through all the special considerations that you've already done. And then I'm going to be looking for hypotension, dizziness, and Jay start telling me everything that's on this list right here about each man. Wouldn't that be nice? Do you think I'm going to ask you a bunch of more questions if you are coming to me and you are spitting out this information to me? When you come to me and say, I don't know anything about that drug, you're going to get drilled up one side and down the other. Because that's telling me now you're not prepared. And I will not, no one in this facility will let you administer any medication if you are not safe. Okay, period. End of discussion. Okay? I need you to come to me, tell me about this. I know you looked it up. I know you recited it and recited it and recited it. And I know you know it, but there's just something about when you walk up there beside Miss Walker. You're like going, my mind went blank. And I know that happens to you. I know it does. I want to make you feel comfortable when you come to me with medication administration, because it's a serious business. It's a serious thing. So just take a deep breath and tell me what you know about that drug. Okay? Things will be wonderful if you do it that way. One of the first things I can tell you I'm going to ask you is, have you verified your doctor's orders with the mark? I'm telling every one of you now, I'm going to ask you that. If your response is, no ma'am, I have not, then you are going home. I'm not going to ask you another word. Because that is one of the first steps of medication administration. Okay, if you say yes, yes ma'am, I have verified all my orders, then we will continue. Okay? So I'm telling you up front, I told every one of you I'd be honest and I'd be up front with you and tell you what I expect of you. And that's what I'm doing. So you tell us, have you verified? Yes, I have. All right. These are other things, and I've just given you just a couple more questions. Remember what I told you about dosage ranges. Do I need to say it again?
No, but I had a question. Like, Northeast, I guess, is a more advanced hospital than Rowan, and you said y'all just have to click on a little thing on the computer and it tells you. So, do we at Rowan find out that information?
To make sure it's okay in the dosage range, it's in your book, in your drug book. So when you start looking at your drug, it'll first say classifications, then it'll say the action, and then it'll have dosage range. And sometimes it will have it broken down in older adults, it'll have it in middle-aged adults, and then it'll have it in pediatric patients. Okay, so it'll have it all there, and it'll say, let's say for instance, lisinopril. The dosage range is 10 to 40 milligrams BID. Okay? Your patient's given lisinopril 10 milligrams BID. So what's the total in 24 hours that patient is getting? 20 milligrams. What is the dosage range? 20 to 40. 10 to 40. 2 times a day, so that can have up to 20 to 80 milligrams, and your patient is getting how much? 20? Is that within acceptable dosage range? Yes. So we're just going to ask you, is the medication within that dosage range? And you say yes or no. If it's outside of that range, we need to talk about it. We need to figure out what's going on. Why did they not order? And it may not be something you can do anything about. Okay? But we need to have clarification. And the first person I call is who? Pharmacy. I call the pharmacy first. Here I am calling people again. I call the pharmacy first and say, you know what, my drug book says this. You know, it's saying that this dosage is higher than I really want to give the patient. And then they can give me some type of explanation or, yeah, we need to call the physician. There's been many times that we have found errors in the dosage range. And we have called the physician and said, or had to call the physician and say, you know, this drug, this is too much. The pharmacy would call them or whatever. So we need to make sure that the dosage range, no, I do not want you to memorize it all. No, not. Okay, we're not going to do that. We are going to just look at it and see if it's in the normal range or not. Okay? You know that you're going to be looking up everything in your patient before because you're going to do that on prep. Okay? So I'm not going to do that. All right. This is something that you have got to take to your grave. Take to your grave. All right? I mean, I'm not wanting y'all to die right now. I want you to know. There are rights of medication administration. This is the number one thing that State Board of Nursing is going to ask you about. Medication administration, the rights of the patient, or the rights of administration. You have to follow every bit of these every time you administer any medication. I think I've listed 10, yes. But I can tell you that these 5 rights right here will be checked 3 times with every medication. 3 times. I don't care which 3 times it is. I'm going to give you a scenario when would be the best to do it. But I can tell you, you're probably going to check it 15 times, especially before I get there, or your instructor gets there. But I have to see you check it 3 times. If people would check their medication 3 times, there would not be errors. Okay, it would not, because first of all, we have verified that the MAR matches the doctor's orders, right?
Yes.
That's not considered a check. But we verify that it says the right thing, right? All right, now, what you're going to do is you're going to actually go to wherever you get the medication out of. Northeast is called an Omnicell. Rowan is called a Pyxis. It is a medication machine. I don't care what the name of it is. The same principles are to be carried out on medication administration no matter where you are. No matter what machine you have, these principles are the same. So using an excuse, well, I was at Rowan last semester. I don't care. The process of medication administration is the same. Okay? I feel like a preacher sometimes. Maybe I missed my calling. All right. So what you're going to do is you're going to have that MAR right there. Then you're going to go to the Omnicell Pyxis medication machine. Okay? And I'm going to help you. We'll figure out how to get in there. Don't stress about that. Okay? We're going to pull up your patient's medications. When I pull up your patient's name, all of his medications are going to pop up on the screen. And I've got my MAR right here. And I'll look at the first one, ferrous sulfate. Then I'm gonna scroll down and I'm gonna find ferrous sulfate. And I'm gonna click. And then the drawer's gonna open, and it's gonna tell me where the ferrous sulfate is in the drawer. I'm gonna pick in the drawer, and I'm gonna pull it out. This is where your first check happens. When I pull it out of the drawer, I'm going to say, this is for Mr. Jones. Which right is that? Right medication. It's ferrous sulfate. Right medication. It is 300 milligrams. Right dose. It is to be given PO at 9 o'clock. What did I just do? I verified the 5 major rights of medication administration. Okay? You have to do that with every drug. As I pulled it out of the Pyxis, and then I came over here in the med room, and I'm going to lay my sheet, my MAR down, and I'm going to grab the first drug, and I'm going to go to ferrous sulfate. Mrs. Jones. There's my medication. Ferrous sulfate. Medication. 300 milligrams. PO. 9 o'clock. What did I just do? My second check. Okay? Usually what happens then is that's when I come in. You say, I'm ready, Miss Walker, I'm ready. So I come in now, and I'll say to you, what's my first question? Did you verify your MAR with your doctor's order? Yes, ma'am, I did. Tell me if you've done your checks. What did you check? And you can say, this is Mrs. Jones. Here's ferrous sulfate, 300 milligrams, PO, 9 o'clock. That's going to be your first. Okay. Then you're going to start telling me about the drugs. Okay, after we do one, you're going to tell me about the drugs. Tell me all that good stuff. Now, when the actual third time is considered when you go into the patient's room. Okay? At Northeast, and I'll try to get, I'm not sure exactly what happens at Rowan, but it's not going to change. But I'm going to tell you what happens at it's the same principle. When I go into the patient's room, the first thing I do, before, I've done 2 checks, okay? I'm saying I've done 2, but I know you've done 10, right? Before you get in there. I am going to look at that patient and say, can you state your name? State your name. State your birthday. Tell me your birthday. That is the first way that you identify your patient. You have to identify your patient by 2 methods. Okay? Don't confuse this with the 3 checks of medications. This is another check. Okay? So we're checking our medication. We're checking the 5 rights 3 times. We have to identify our patient in 2 ways. What would be my other way? You need to take and look at that armband, and you need to verify it with your mark. You need to look and say, Mr. Jones, it has the birthday on there, and it has the birthday on the mark. Should there be any reason why you should give the wrong patient the wrong meds?
No.
No reason whatsoever. You should never, ever give somebody, if you do those checks, you will never administer the wrong medicine to the wrong patient. Now, I know somebody's getting ready to say, Miss Walker, what if my patient can't talk? You have an armband that you identify. If there is a family member in there, you can ask them to verify who that patient is. But if they are nonverbal, you have to go on the armband.
You can also go off for chart, can't you? Because we do still have charts at Northeast, the wood charts.
But we don't take it into the room.
Well, no, but if you need to verify twice, you don't take it.
The good thing about Northeast is that I can check the armband with my own eyes with the mark, but I scan. So when I scan their armband, it's going to pull up his information. So that's basically another method. My thing is you are not, if your patient is verbal, you are not depending on that scanner to do your second check on the patient. That's an additional check. If your patient is able to talk to me and tell me, my name is Leanne Walker, my birthday is 4/7/64, I have no allergies. Okay?
What if they don't match up for some reason? Like our patient tells us one thing and when we scan it, I mean, obviously in cases of dementia sometimes you get things like that.
Exactly. Then I'll not administer any medication to anybody unless I have verification that that is who it is. And I know for sure that this is the, that's why you've done all those verifications prior to coming in to the patient. In other words, you verified the MAR with the doctor's orders. You have done all your checks. So you know that these medications right here have been ordered for Mr. Jones. You know that information before you go in. Okay? Then when you are verification of him telling me, I'm Mr. Jones, my birthday, or his birthday, and his allergies, I'm looking on the MAR. That is another way I'm checking. The scan, and I'm looking, actually physically looking at his armband and making sure that it's the same. If it's not the same, my medication administration stops at that point.
What do you do if they tell you like their name is something else in there?
And they will sometimes just joking around with you.
But if they're like either cognitively there or like for
You have to
whatever
find
reason,
somebody in a family member that verifies with you, or one of the nurses to verify who it is. The biggest thing is that you do not continue that medication administration if something don't match. Okay? Now, a lot of patients like to cut up with us and tell them that they're Marilyn Monroe and Ronald Reagan. You know, they do. But you have to at some point say, I'm serious. I'm not going to give you your medication until I know for sure that you are who you are. Okay?
I had that happen to us, me on my first day. The nurse went in and was giving him his medicine. And she's like, what's your name? He said, Fred Flintstone. She said, I guess I'm in the wrong room, and turned around and went to go out. And he's like,
Good
where
for
you going?
her.
I need my medication. She
Good
said, well,
for
I need
her.
to know who you are.
Exactly. Go, sister. I am so proud because that's what it's supposed to be. It's all about making sure that that patient is who they say they are. Stop it. Don't go any farther. But if you're not who I am, I'm going to find my right patient.
And that's what she was doing. She turned around and was going out of the room.
Good for her. Love it. Like she must have been one of mine. But yeah, you see to where the principles are, and see if you follow these principles, we're not going to have medication administration errors. We're not going to, I mean, we're all human, and sometimes we're going to do something crazy sometimes. But if you follow this and you practice this for the rest of your life, you're going to be safe. You're going to be safe. You're not going to have a problem. So, now that I have identified my patient, I then, for that third time, I'm going to verify again. And at that point, after I have verified for the third time the right patient, the right dose, the right med, the right route, and the right time, I now can open it. and I now can start administering the medication. Okay? So, please tell me that you are going to verify how many rights of that patient. 5 rights, 3 times. Identify your patient twice by 2 ways, which is verbalization of their name, birthday, and allergies, and RMD. If you do that, should you have any problems?
No.
So why is medication administration so scary? It is scary.
Yeah.
But if you do this, should it be scary?
No.
Shouldn't be a problem whatsoever. Now there are some more rights that so it doesn't just stop after I've done this and I've administered it. Of course, documentation is going to be vital. We will show you how you document, because if you don't document, you didn't do it. So we will show you whatever facility you're at, we will show you how to document. But you have to immediately tell me, Miss Walker, I've got to document my medications after my patient's swallow. Okay? Or whatever. We have the responsibility to make sure that that patient is educated. It's a perfect time to say to that patient, you know what, this is your blood pressure. This is for your blood pressure. What do you know about your blood pressure medicine? And then this is a wonderful time to figure out, what do I need to teach them? Okay? That is our responsibility too. Patients can refuse any drug or any medication that I want to give them. They can refuse it. Okay? I don't have to take anything that you bring to me. So the biggest thing, what I usually do is I don't open everything until I know for sure they're going to take it. Things like Metamucil and, stool stop. Sometimes I get, I had 4 VMs last night. I do not want any Metamucil this morning. So I'm not going to mix that up or fix that. I take that in and just say to them, are you wanting this today? No, I put 4 times. Don't need it. Okay? So I haven't, first of all, charged the patient for it. Second of all, wasted it. Okay? So, but there are going to be times that you may possibly go ahead and have opened it before they say, I don't want it. We have to document that they refused it. Because if we document it any other way, then it's going to look like we gave it to them. Okay? At your facility, we will show you how to document if a medication has not been given. Okay? We will show you. We will teach you how to document if it has not been given. Okay? Because every facility is different. Now, for your checkoff purposes, you're going to be given a MAR. Okay? A paper MAR. And you're going to be writing in if you gave it. So what you're going to do is when you check off and you have administered your medications to your patient, you're going to say, Miss Walker, I now need to document. You're going to go beside each drug that you gave and put your initials there. That is saying that you gave it. Okay? And there again, I will show you when we practice, I think 2 weeks from now, that big clinical day that we practice, I will show you how to do that. Okay? So I will show you how to document. If you do not give a medication, the patient refused it, then you need to put your initials there and mark a line through it. But you need to put something there to say why you didn't give it. Something like patient refused. Okay? Now, patient's MPO. You've got 14 PO meds to give him at 8 o'clock in the morning. What are you going to do?
Most of the time you're around 6.
That this patient, nothing. Nothing by mouth. But you have 14 meds to give at 8 o'clock.
Call the doctor for order.
Don't give him the meds. Call the doctor. He don't know what's going on. I'm going to take care of this patient.
You just hold the meds in.
15 POs. And he's MPO. What are you going to do?
Just hold the meds.
Y'all are making this too hard. NPO.
Nothing by mouth.
Nothing by mouth. But you have 15 PO meds.
Find another route. Find another route.
Tell me somebody, say it out loud. Nothing by mouth.
Nothing by mouth.
You have 15 minutes to give him by mouth. What are you going to do?
Don't give them.
Don't give them. Don't give them. Because the patient is NPO. Don't give it. You're going against the order. You made that too hard, didn't you? He might need, but there's a reason why he is NPO. What if he has to go to surgery? What if he's having a test that says you have to be NPO before you can do this test? But I'm going to give him his meds. And then he's going to get down to have his test done, and what are they going to say? We got to cancel this test because your nurse didn't follow the order of NPO, and we got to make this patient go through the prep again because I didn't miss the NPO.
That's the case of giving the medicine when it's back.
Exactly. It's not that I'm never going to give my patient his meds. But right this moment, he's NPO. And I can't give it. So when he comes back from his procedure or whatever, then I will look and see what medications I need to administer at that point. And yes, they'll be late. They'll be late. But don't I have a reason why they're late? So all I have to do is do what? Document. Document why am I late? Jessica.
Of course, if there was an exception like thyroid medication,
No exception. NPO means NPO.
that's what I'm saying. If it says NPO, except for.
That's not what I said.
But
NPO.
What if?
Period. I didn't say what if. I didn't say what if. I said NPO. Period. Now there is a time that you could go NPO except meds. And then what would you do?
Give him meds.
Okay. All right, question.
What if, like, he had a test in the morning, you didn't give him his morning medicine, would you give him his noon medicine when he come back up at noon? Yeah.
What?
I mean,
Yes,
I'm just saying, I mean, because you weren't able to give him his medicine for the morning, so you just would go to the next.
I'd either go to the next time that he gets back and he's not NPO, then yes, I will look and see what medications, if they were daily,
Like daily.
not a problem giving it to him. But if he has another set of drugs that were due at the same time and it was the same med that morning, no, I'm not going to give him a double
That's what I
dose.
thought, I just wanted to be sure.
Will the physician write an order, if he makes the person MPO, will he write an order for a med that has to be given IV? Like, will he replace it? Will that ever happen?
If the medication is vital and he has originally written it for PO and that patient has to have it,
Right.
he will rewrite the route.
Like one time?
Right.
Like if they have to have something for nausea when they come out of anesthesiology or something.
But what's the route?
That's usually IV.
Right. So the moral of my story is, if they are NPO, you do not give them anything by mouth. If they have a sub-Q injection, are you going to give that?
Yeah.
If they have IV, You gonna give them that? Okay. Nothing by mouth. Period. Period. Don't give them anything by mouth if it says NPO. And I know y'all always say, well, what if this? What if this? What is this? Listen to what I'm saying. NPO. Nothing. Okay? Lord have mercy, y'all. Drive me to drink sometimes. All right. I just went through the 3 checks. This is a little lady doing her 3 checks. We've talked about, first of all, look on here and see if there's anything you don't know what it means.
There's a bunch I don't know.
Okay, well, we'll go through every one of them. First one, AC. Before meals. Right? Ad lib.
No assistance required to get up.
Get up. No assistance needed whatsoever. They can get up by themselves. Ad lib. They can do whatever they want. AM. Morning. BID. Twice a day. Cap. It is a capsule. Why do you think that's important? Absorption and swallowing and
Not able to crush.
huh? Yeah, the right medication.
Not able to crush.
Not able to crush it. Can you crush it? And what if the drug says in your book crush? If it's a capsule, you can. Okay. GTT. Drops. That will make more sense to you when we do IVs because you're going to be doing drops per minute. Okay. H or HR. Okay. Now that has to be written out hour. Okay. You can't use that H. Has to be written out hour. Should have read that out. IM. Intramuscular. IV. Intravenous. NO. No. I don't know why I put that no up there. No means no. NPO. That's probably what you meant. I probably needed an NPO. That's what I meant. Put a PO in there. PC. After meals. After. So after they eat, you gotta give them their medicine. PO. PM. In the evening. PRN. As needed. QID. Q2H. Every 2 hours. Q4H. Q6. Q8. Q12. RX. Prescription. Stat. How many minutes? 5 minutes. Tab. Tablet. Tablets can be crushed unless they are
Extended release.
extended release or enteric coated. Enteric coating pills cannot be crushed. Why?
It affects the absorption.
There's a reason why that coating's on there. Right. It's not the absorption of it is the reason why it has that coating. And when it has that coating, if I crush it, the coating's off, so the drug ain't working. I will tell you my little story about my son and this release drug. You know, there's some medications that are timed release. You know what I mean by that? It's like once they take it, just a little bit goes out at a time, and then a little bit goes out at a time, and a little bit goes at a time. Well, my son was on Concerta, and he was just on a whole pill. He just thought, Mom, I am so zoned out. I'm not I just don't feel like myself. So Nurse Walker here decides she cuts it in half. I thought, here, we'll do this. I cut it in half just as per as you please. Was not even thinking that this was a time release medication. not even thinking. So, a couple days go by. How did that half a pill work for you, Dylan? Mom, I can't really tell I took anything. Oh, maybe because I wasn't supposed to cut a time relief medication and it did not work appropriately. Nurse Walker did that. So I didn't have any medication errors on patient, I just had medication errors on my son. I OD'd him on codeine when he was a baby. So, anyway. Okay. All right. We did that too, didn't we? All right, y'all ready to take a break? Because then we're going to, can you find where I'm at now? One of the injections sites is going to be intradermal. All of you had your TB test, right? Mm-hmm. Okay. When you give an intradermal injection, it goes just under the first level of the dermis. Okay? The whole object of it is you can actually see with this one, with the top one, is you're going to use a 10 to 15 degree of an angle when you go into the site. There's only about 0.1 to 0.2 milliliters that you would give intradermally. Okay, that is very little amount. So if you have a large amount of solution that you've done your calculation and it says, oh gosh, I should give a whole cc, and the physician's ordered it intradermally, that is not something that you can do that route. That would be something that you would contact him and say, this is not to be given. That is too much fluid to be given intradermally. Okay? It is very little. It is 0.1 to 0.2. With any injection, it is the nurse's responsibility to pick out what needle you are going to use and what type of syringe you are going to use to do this injection. There are two major different things that you're going to see with each syringe and needle. One of the things that you're going to look for is the length of the needle, how long it is. The other thing that you're going to look at is the gauge of the needle. Do you know what I mean when I say gauge? How big of an opening it is. The thing with gauges is that the smaller the number, the bigger the opening. Okay, so you got to remember that smaller numbers are bigger holes or bigger openings. Okay, so a 16 gauge is big. Okay, a 27, 28 gauge is smaller. So the way you make that decision, there's several factors that you've got to look at before you make a decision on what size length of needle and what gauge needle that you're going to pick to give your patient. The first thing you're going to look at is, where is this going to be given? Is it going to be intradermally? Is it going to be subcutaneous? Is it going to be intramuscular? Depending on what tissue we're going into, depends on how long of a needle I need and how big the gauge is. With an intradermal site, you don't need a long needle. And you don't need a very big gauge because it is a very small amount of fluid that's going in, and you definitely don't need a long needle, because where are you going? Are you going down deep? No, you're just going to need something to help go under the first layer of skin, and so you don't need anything long. When you give an intradermal injection, it is, I want to say it is always, but when I say always, that gets me in trouble. It should be given in the left forearm. There's only, should be left. Now some people give it in the right, and there's nothing wrong with that, because the site is the same on both arms. When you hold your arms out, you can look that it needs to be right here in the forearm. Okay, so right in here. So if you want to look on yourself, it's right in here. Yeah. Just right in here, this area right in here. You don't want to go too far up in the crease. You don't want to go too far close to your wrist. So right in here, this area right here. And what you do with that injection is you just go at a 10 to 15 degree angle. Always have the bevel up. You know what I mean when I mean bevel? The syringe goes like this, and then it has a little slant down when you hold the syringe. And you'll be able to see it when we bring our equipment, and I'll go over it again if you're having trouble. But the bevel goes like this. It's sort of like an angle at the end of the syringe. With intradermal, it is vital that you have that bevel up. So as soon as you go under the skin, you inject the medicine, and it'll make a little bubble. Okay?
UV skin test.
That's exactly, that is the only drug I have ever given intradermally. You're just not going to see it given, anything else given intradermally. Okay? But you need to realize when you're going to be the one to, with whatever route the physician has ordered, you're going to be the one that's responsible for figuring out what gauge, what needle length you need for each patient. And it'll make a little bit more sense once we get to the other areas that we're going to be giving injections. So intradermal is one. Subcutaneous. This is when we can start finding the sites on each other. Subcutaneous is exactly what tissue that you're going into. So isn't that a little bit lower or deeper than the dermis? So wouldn't you think you need a little longer needle?
I was going to ask too, I've heard the left or right too, but why the left?
I think there's probably not any rhyme or reason to it, but it's just to help when patients come back for us to read it in 42 hours. We'll know to look in the left arm.
That's what I thought.
Yeah, there's probably not a rhyme or it's just something to help us, because sometimes the patient will go, I don't know which arm you put it in. So if I go look on the right one and that's not where they gave it, I'm reading a test that is not where it was given. Okay, so we put it in the left, and that's just universal, and so we can help and make it consistent. All right, so subcutaneous, I need a little bit longer needle, and I also can give more fluid in that. Whereas an intradermal, I can't give at 0.1 to 0.2. I can give more fluid up to a whole cc when it comes to subcutaneous tissue. Okay? The different, and I'm not going to actually show you how to give an injection. That's going to be on our practice day. I just want you to start getting familiar with the sites and you having to pick the gauge and the needle. Okay? Also, when you give a subcutaneous injection, you can go at a 45 degree. Now the research is saying that you can go at 90 degrees as well. Okay? But you can go 90 or 45. Either one, depending on where you're at. And I'll show you the difference when we get to the different sites that we're going to practice on, and to see when is a good time to use 45 and when is a good time to use 90. Okay? So, let's look at the sites, because I want you to get a partner. And everybody should have a partner. Yeah. Everybody should get a partner. All right. One of the first areas that you're going to give sub-Q injections are in, it's going to be the outer aspect of your arm. Okay?
A muscle.
That's intradermal. I mean intramuscular.
It's sore.
Okay. Your flu shot should have been in intradermal. I mean intramuscular.
It was right there.
Not, yeah, right here. That's not, we're going subcutaneous. And you can see,
We're going more down into the fatty part of it.
you want the outer aspect of your arm, where the
I got
flab is. Okay.
Or whatever. Outside of this. Really not supposed to
Don't go on down like here. Okay? It needs to be out right in here. This is not muscular, so it shouldn't be going in the muscle. Now, how am I going to make sure it doesn't go to the muscle? Because I will use a shorter needle, right? If I use a longer needle, that means I'm going to use muscle.
This muscle here can't take more than one
That's what it comes to. You have to assess your patient and see. If I have someone who's very, very skinny,
So if
right
you
here, and they don't
get a test on your questions that you
I
have to
gotta
give an
find
eye,
somewhere else.
your dose is 1.5, what would you do?
That,
You either look for a different size
still have a
or
little
break it
bit
up. You get one in here,
tissue.
1.5
I have to look, and I may have to adjust.
But you would
how
never get
deep
more
I
than one
go.
in your deltoid.
If I've got somebody who's really, really skinny, even though I know that I've got a 5/8 needle, I may not be able to take it all the way in as 5/8. See what I'm saying? I may have to stop it before I inject all the way, or before I go all the way. So, Jeff's bringing up, what is? So, listen guys, when you have your patient, I'm just going over sites right this moment, but every time before you give your patient any injection, you are going to assess a site that is going to be good for that type of injection. That's what you're going to make your judgment call on what type of needle, lengthwise, and gauge-wise, depending on what your patient's body frame is like. If you've got a really skinny person, unlike myself, that doesn't have a lot of subcutaneous tissue, that means I'm going to have to go look at every site to make sure I find the best site that has the most subcutaneous tissue. Okay? And I may have to be there for a while to figure out what's going to be the best place for them. Okay? And I may, and this is what I was telling Jeff, sometimes you've got to maybe even adjust that I don't inject the needle all the way. If they're that skinny, if I may have to just inject it a little bit and then inject the medicine to make sure I'm in the subcutaneous tissue, because that's where it's supposed to go. All right, it's got to have a lot of tissue there, not a lot, but some. Yeah, your older patients who don't have a lot of subcutaneous tissue, that is when you're going to use us. But I want you to go in there and assess your patient, and I want you to start, I mean, not that I want you filling all your patient, just tell them, I need to give you an injection. I need to find the best place that I can give this, that it doesn't hurt you, and that I get it in the right place.
What is normally a subcutaneous medication that you give?
Insulin,
Insulin was a big one.
heparin, Lovenox, those kind of things. Huh? Allergy shots, exactly. That's the most common one. But here is the best place for you to go in this lymphatic tissue. You don't want too close up here to your shoulder, and you don't want too close. And I usually say a hand breath. If you put a hand breath here, I'm not going to go above there. I'm going to start right in here. And then a hand breath here. And so, you know what I mean by hand breath?
Not really.
The width of my hand. Yeah, so I just go right here, and I know I'm going to go above that. And I go right here, and I'm going to go after it. And it's going to be this fatty tissue right back here. Okay? The other areas is on your thigh or on your legs. I definitely do a hand breath here where your growing is. Okay? So start with a hand breath here. Are y'all being nasty?
It's the Pacific growth.
Yeah. Put a hand breath here and a hand breath here. Right above your knee. Put a hand breath. Your knee. That is a lot of room. There's just like a lot of room. It's very short. Like me, you may not have a lot of room. Okay? When you go in here, let me just sort of draw this and see if this will help. Now, I'm not an artist by any means. There's your thigh. If I put a, don't laugh at my thigh. And here's my knee, my kneecap. I'm going to put a hand breath here, so about right here, I'm not going to go any closer here. And then I'm going to put a hand breath in my groin here. Okay, so I have this area right on the top of my thigh. And if you divide that into 3 different areas, so 1, 2, and that'll be 1, 2, 3. I want to give it in this area right here. In the middle part.
Is that how they give immunizations or immunizations intramuscular? Like I'm thinking about my little boy, that that is on his side.
On his side, which is intermuscular.
It is more on the side.
Yeah, side is muscular. The front, the top is subcutaneous. Okay? And I'll show you muscular in a minute, and you'll be able to see the difference. Subcutaneous is on the top. Hand breath, and if you have your person stand up and start feeling their legs, does that feel like muscle right here on the top? Stop muscle. On the top. Feel on your page, feel on your partner. That's not muscle. Alright, now tighten your legs. Tighten your legs. Where's the muscle? Where's the muscle? Can you tell the difference? Yeah. If you tighten your legs, you got a little muscle on the side.
Yeah.
Don't show off. Don't show off when you got muscle. You got muscle in the front. I promise you that is not. But it's somebody is muscular there. My son's girlfriend is a bodybuilder, and she's got muscles where I never even thought they were things that could be muscles. But anyway, if you are concerned about getting in a muscle, what would reassure you that you're not going to the muscle? smaller length needle. Because if it needs to go to the muscle, it needs to go deeper. And it'll have a longer needle. Okay? Now, the other places that they tell you that we can give intramuscular or subcutaneous is right here in the scapula area. Up here. That is subcutaneous tissue. I have never, ever, 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 ever given an injection right here and probably never will. Okay? You also, you know your little love handles right here? That's subcutaneous tissue. That is a approved site. Now some of you skinny minis may not have it. You need to feel it. I got to need it. Right here. That is an acceptable site for subcutaneous. Am I going to give somebody an injection there? Probably not. Probably not. Don't feel like that is really, really good.
Because I don't do shots now. But when I did, then I would go back to
But the needle is not, it's going to be really short. Really, it is short. So that's why. And it's not going to go so much.
Okay. Well, I'm just
It's more concerned, I'd be more concerned if I was wanting to give an IM here.
okay.
See what I'm saying? Because that's not going to make it to the
Unless you have a really deep or look long.
Right.
Okay.
And there's more muscular here.
Okay.
But subcutaneous should be given on the top. The top. Here, 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 and of course our wonderful belly. Now let me just tell you what you got to stay away with from your belly. Your belly button. I know there's another term for that, but your belly button, you need to at least stay 1 to 2 inches away from that belly button. Okay? Don't go near the belly button when you're giving an injection. Some of the new research is saying that this, down on this side of the abdomen, right here, can y'all see me, is the best place. So there's like a little, whatever.
Yeah, like that.
Is that a B?
It's actually a muscle.
It's a
Like this right here. All right, show your skinny self. Show your skinny self. Sit down, skinny. Ain't fair. I want to be skinny too. Right through here. See how I'm plenty of subcutaneous. You're saying that works better than actually eating. But you know eating right from the belly. Are you never playing that?
Is that your tracking device?
1 to 2 inches from the light. Stay away from there. Now, who are the most common people that have a lot of sub-Q injections? Diabetics. So when they come into us, they've been giving themselves shots lots of places. So what do you think would be very important that you want to educate on them? Alternate their sites. Please don't give them the same site or give the injection in the same site because it's going to tear down the tissue. A lot of times what I do when I first go in to give the injections, and we gave an injection this week with one of our patients, and can y'all remember one of the first things that I asked her? I don't remember who was with me. Where does she normally give her shots? Okay? Because if she's in the hospital, I want to stay away from those areas. Okay? Because she's used those shots over and over, those sites over and over and over again. So if I can, I want to stay away from there. Most of the time when diabetics give themselves injections, they can't give themselves here. That's sort of hard. So they usually use their belly and they usually use their thighs. So while they're there, well, I want you to stay away from that area. I want to use back here, and that's when we ended up giving, well, we gave one in the belly. Oh yeah, we gave one in the belly because which was very selfish on my part. I wanted all the students to actually see me give the injection, so they were sitting over here, so we used her belly because we couldn't get anything else. So that was selfish on my part, but it wasn't fat area. It was still a good spot. But anyway, the next one, we gave it in the thigh because she never uses her thighs. So I want to make sure that the tissue that she's using all the time, I stay away from. Okay? All right, so with subcutaneous, I know I need to have a needle that's how long? 3/8 to 5/8. I want the gauge to be.
25.
Did I not put it on there?
25.
Okay, sorry. Sorry I went over there. Okay. So I want it to be 3/8 to 5/8. I want it to be a 23 to 25 gauge needle. And I'm generally going to not give more than 2 mLs. Okay? You're generally going to get around 1 ml there. Your book says you can give 1 to 2. I don't feel comfortable giving 2. 1's going to probably be my max on subcutaneous. So, but your book does say 1 to 2. You can give it 45 to 90 degrees, and this is just a little rule of thumb. When I said the research now says you can give it 90 degrees as opposed to 45. If you use 45 degrees, when you've got an inch that you can pinch up of skin, then it's okay to use the 45 degrees. If you have 2 inches that you can pinch up, like on me, you might have 5 or 6. You can go in at a 90-degree angle, and that's okay. So that's going to give you some kind of rule of thumb to look at to make that decision. If I can't pinch up a lot of it, I need to go at 45 degrees. If I can pinch up a lot, go for the 90 degrees. Now, tell me the sites again.
The bottom of the thumb.
The outer part of the arm. Okay. The tops of the thigh in the 2/3 in the middle. My belly, I'm going to stay away from the belly button. Scapula, and back here. Good. So you're going to make that decision when you assess your patient on what's going to be the best site, right? All right. Now let's go straight on to intramuscular, and I think by the time we do that, you'll be done with me. Intramuscular goes deeper, right? We need to stay away from bones, obviously, because that needle can be up to 1.5 inches. Now, 1.5 inches, that's a long needle. Now, when do you think do you not think this is going to be major important for me to assess my patient before I decide to use 1.5 inches? Please don't bring me 1.5 inches when you're an 89-year-old lady that weighs 90 pounds. Because we're going to end up hitting bone, for sure. Okay, not going to be not thing we want to do. You're going to use 20 to 23 gauge, and 1 to 5/8. 1 to 1.5. There have been times when I have skinny patients, older patients, I've had to use 5/8 on. That is very, very rare, but there are times that I've had to. For testing purposes and for boards purposes, you need to know the gauges and the lengths for each injection, the ranges that you would use. Because you may be given a situation and you're going to have to say, I'm going to say, Chelsea, this is your patient, go assess her, and then she's going to have to make that decision on what size gauge and what length she needs to give or pick out to give this patient the medication. Okay, so you need to know. And we also go in 90-degree angles with that. And you can see that goes straight down into, that's 1.5 inches right there. Straight down into the muscle. Okay, now let me do the not so fun ones first. Deltoid. I was like, what is the name of that muscle? I just had a major brain move. Come here. You're skinny. I want you. All right. find this little notch in your shoulder. Okay, that little notch. Feel that little notch? All right, then you want to put your hand right there. So you're going to do a hand breath down, and you're going to go right here in the muscle. We're not going back in this tissue back here because that's subcutaneous. That is right here. You also, if you do a little triangle like this, the muscle is a triangle. And it goes right here and go down. You want to get right in the middle of that triangle. Okay?
You want to go under your hand or?
Yes. Put your hand. No, I'm sorry. Let's do 3 hand, either 2 or 3 hand breaths. We do finger breaths. Let's say hand breaths. Yeah, let's go 2 or 3 there. I think that whole hand's gonna be too far down. 2 or 3 finger breaths down, and then go right here. And if you pinch up, you'll be able to feel that muscle. Or have her tighten up, and you can feel that muscle. I'm not going to feel a muscle there. Okay, find this little notch here. 2 to 3 finger breaths down. And then right underneath that. So be in that little triangle right here. That should be in the area that y'all have received your flu shot. Okay? Alright, keep poking. It should bruise, but sometimes we bruise people, sometimes we don't. We do, sorry. Alright, the vastus lateralis. This is the deltoid. Let me tell you something about the deltoid first. When you're trying to make a decision on where you want to give your injection, if your injection is more than 1 cc, you will not use the deltoid. Okay? You never give more than 1 cc in this deltoid muscle. Okay? So if you did a calculation and you got 1.5 is the amount of medicine you need to give your patient, you can already mark off that the deltoid is where you cannot give it. So when you're assessing your patient, you know not to even look at the deltoid because it's 1.5. And I cannot give more than 1 cc in the deltoid. Okay? All right, the vastus lateralis. The same thing with doing your finger breath here and bring finger breath there. Hand breath and hand breath here, but you're going on the outer aspect of your thigh. And you divide it into 3 different areas, and then you're going to go in this area right here. Okay? Now tighten your muscle. We just did it a minute ago, but tighten that muscle. And you can feel where your muscle is on the outer aspect. Okay? So intermuscular on the vastus lateralis is on the side. Okay? Alright, is everybody feeling the vastus lateralis?
Yeah.
Alright, I need a volunteer that's going to let me feel their behind. I might need you to stand up here.
Am I facing this way?
Yeah, you'll face. Actually, if you want to stand up and face that way.
I'll wear a shirt.
Okay, good. I'm glad. All right. This is the ventro. Are you trying to ran for? No, you're not ready.
Back there making music.
You better not be.
I won't do that to you.
The things I do for my class. Okay. Ventrogluteal. V. We're going to make a ventrogluteal. All right, if you put your leg up just a little bit this way, okay? When he does that, his greater trochanter is going to pop out for me. There you go. greater trochanter is right here. It's going to pop out. What I'm going to do is I'm going to put my palm on his greater trochanter, which is right here. Let me hold you.
Okay.
Got it?
Yeah.
Right here. Then I'm going to put my index finger on his iliac crest. Okay, so I've got palm on greater trochanter, right?
Yep.
My index finger on the iliac crest. I'm going to spread into a V. See my fingers? They're a V. And right there is where I'm going to inject. Okay? Right there. Not back here. Okay? Right in there. All right, now, can y'all see? Do I need to turn him around?
Yeah, turn around. There you go.
Is that better?
Yeah.
All right. Put your knee right there. And the reason why I have him put his knee up is when you, and you can do this when you stand up in a minute. When you, the first thing, okay, wait a minute, let's just get up here. When a patient knows that we're going to give him an injection in the behind, what is the first thing we want to do? Tense up. If you have him put his leg up like this, try to tense up your butt. You can't do it. Okay, so he's not going to tense, and it's not going to be as painful to the patient because he can't tense as much here. Okay, so when he pop, the other thing is when he pulls up, that greater trochanter is going to pop right out. Okay, greater trochanter right here. I'm going to put my palm on it. I'm going to find his iliac crest, which is right there. I'm going to spread into a V, and I'm going to inject right here.
And see him injected between the.
Right, inject in here. Now, obviously, you're not going to inject with your fingers still sitting there. Okay? Now, another thing I want you to realize is, you can put your legs down. We used to, that's the ventrogluteal. We used to do the dorsogluteal. We're not using that anymore. Where is the sciatic nerve? Where does it go?
It goes right down the bottom.
Right down through here. So what was happening is the nurses were not feeling landmarks good enough, and they were dividing the buttocks into 4 different and going right there. And they were hitting the sciatic nerves, and we were paralyzing our patients. Okay? So we do not use the dorsogluteal anymore. So if you've got any information on that, just mark it off. Because we're only going to... Thank you, darling.
Yeah.
Let me play with your behind. All right, so now this is when you got to find your partner. Okay? And practice finding this greater trochanter. Stand up.